Good morning, everyone. This meeting's come to order. We were having a little technical difficulties, but we're on track now. Welcome to the June 29th PEB Board meeting. Our meeting will continue to be hybrid. Healthcare Authority staff will be on site. Board members and other attendees will have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information how attendees can turn on closed captioning. Let's go with board member intros. John? Not here yet. Is he going to be on? Or
we're expecting him in person.
He's en route. Tom?
Yes, Tom McRobert, WA retired rep.
Harry?
Yeah, Harry Bossy, Benefits Management, Cost Containment.
Elliot?
Elliot Weinstein, RPEC Retirees Rep.
Monica?
Monica McLemore, Professor, University of Washington. My apologies, I'll be in and out of the meeting today because of the Supreme Court ruling from this morning.
And quickly, congratulations, Monica. Can you tell everyone about your new role that begins tomorrow?
Yes, tomorrow at the University of Washington School of Nursing, I will assume the role of Associate Dean for Equity, Diversity, and Inclusion.
Awesome. Congratulations.
Congratulations, Monica.
Kurt?
Good morning, Kurt Spiegel, Executive Director of the Washington Federation of State Employees.
And Michaela Dolman is going to be absent today. And Lou McDermott, I'm the deputy here at HCA, and I'll be sitting in for Sue today. And Michael Tunick?
Yes, present.
Really?
All
right. You went
Is
with
that
present.
better? Okay. Yeah, thank you, Chair
Okay.
McDermott.
And Michael's from the Attorney General's office. Hey, John. Why don't you go ahead and introduce yourself, sir, and we'll continue on.
Hi, John Comerford. Sorry to be late. Mr. Chair, I'd like to make just a quick disclosure if I can.
Absolutely.
Since the last meeting, I've taken and begun a position at the University of Washington as a benefits consultant. So I just want to make sure that's on the record.
I appreciate that. Thank you, sir.
Thank you. Oh, sorry about that. Thanks.
All right. With board members attending both in person and virtually, it'd be helpful for the board to hold their questions until each presentation's done or when the presenter pauses and asks if there are questions. Board members attending virtually, we will also watch in case you use your Zoom hand, your hand feature to indicate you have a question. There are 2 resolutions scheduled for action at today's meeting, so the public will have an opportunity to provide comments on both those specific resolutions during the normal procedure before the board votes. The public will also be able to provide general comments at the end of the meeting during our public comment period. As a reminder, if the public has questions during the staff presentation, the presenter's contact information is included at the end of their presentation. You're welcome to email them during the meeting to capture your question for response after the meeting. Dave is going to provide us an overview of today's agenda.
Good morning, Chair McDermott and members of the board. Dave Eisminger. We'll start off today with an approval of the last meeting minutes. I think our new process of putting audio on the web is pretty quickly after the board meeting and then bringing you a true summary minutes is producing a much faster turnaround on things. So really happy that process seems to be working out. Then we'll move on to 2 votes on resolutions that were introduced at the last board meeting. The first related to the IRS minimum deductible on our qualified high deductible health plans for 2024 and setting a policy and ability going forward for the agency to simply implement the minimum requirement. And then vote on the coverage of 2 over-the-counter COVID tests in the Uniform Medical Plan effective Saturday, if I remember my calendar correctly. Yeah, Saturday. Then we're going to bring Luke Dearden here to answer a question that some board members have asked, especially over the last year, which is how, the whole process for a drug going from approval by the FDA, how it results in coverage in insurance plans, and just generally how a pill gets covered from FDA approval to plan coverage, and kind of honing in a little bit more on the Uniform Medical Plan specifics. We thought that would be a very helpful topic as we are rounding out our board season. Michelle George, our communications director for the PERB division, will be reviewing a survey that was done earlier this year with members about how we communicate with members. And then we will go into a series of presentations, starting with John Parton going over the benefits cycle and how the flow of work goes in our program on developing benefit changes or developing new benefits within the portfolio. Molly Christie will be here from finance to present the proposed 2024 Medicare premiums, and we are taking a little bit more deeper dive in some of the components of future rates to describe exactly with more detail for you and the public about what is going into that rate process, and also answering that perennial question about how exactly are the rates for the Uniform Medical Plan Classic set. So really excited for Molly to be going through the detail in that presentation. And then as always, Ellen is our anchor with some updates on a variety of different aspects of our Medicare work, kind of doing a retrospective review of the last year of things that have been worked on by the agency and kind of next steps when it comes to the Medicare portfolio and work. We'll have general public comment, and then we do have an executive session that's focused on our non-Medicare rate development, which will be part of our public process and public board meetings in July. 2 housekeeping reminders. First, earlier this month, I won't do this every meeting, but I'm just going to do it for the month this month. Reminder that TVW is back with us. They aren't here in the room, but they are virtually recording and streaming and providing more public access to board meetings. So just a reminder that we appreciate what they do for state government in helping citizenry understand and get more access to the work of government. And second, we have a lot more people here in person. I find that personally exciting. It's just a reminder that bathrooms are out the right door and down the hall. If you see elevators, turn left, and if there's an emergency, we go out across the way into the visitor parking lot that many of you parked in today. And with that, I will turn it back over to you, Chairman Durham.
All right, thanks, Dave. Any questions or comments from the board? All right, we have a packed agenda today, and we don't have a break on the schedule, so if you need to utilize the restroom, please just feel free to go and do what you got to do. We will try and squeeze a break in. I was thinking around 10 o'clock or something. We'll see what we can do. All right, we're going to approve we're going to vote on the approval of the June 8th meeting minutes. They're behind tab number 3. We're going to take a vote on the June 8th, 2023 meeting minutes. Are there any comments from the board? Seeing none, do I have a motion to approve the minutes as written?
So moved. So moved.
Is there a second?
Second.
All in favor, say aye.
Aye.
Any opposed? The June 8th, 2023 minutes are approved as written. All right, first up, Janice McAlpin, Senior Account Manager in the Employees and Retirees Benefit Divisions, joining us to present for a board vote and the UMP Consumer Directed Health Plan IRS Minimum Deductible Resolution introduced at last meeting. After Janice reviews the resolution with us, I'm going to ask for a motion to adopt and a second. I'll invite public comment on the resolution, ask for a discussion from the board until we're ready to vote. Materials behind tab number 4. Welcome.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Janice McAlpin, and today I will be presenting on the UMP CDHP Plan IRS Minimum Deductible Adjustment. It's a mouthful. All right, going on to the next slide, you'll see one of the follow-ups that we had from last month's meeting. So earlier this month's meeting, there was a question about what if the IRS guidance results in a lowering of the minimum deductible. And so we just wanted to be clear that we would assess that for any upcoming year changes for rate impacts. But the way that the proposed resolution is worded is that we will align with the minimum deductible. And so if if our deductible ends up being higher than what the IRS comes out with, which we don't expect that to happen just based off of the chart that I had showed earlier this month, it seems to be going up and up, which is why we're bringing forward the resolution for vote. But if it did happen to go down, we would bring that back to the board for a vote, because then we would no longer be in alignment with the proposed resolution. So you would see that come back for a vote. But just as a reminder, that chart did show that it seems for the last decade or so, the minimum deductible is going up every couple of years. And in the last couple of years, it's been going up every single year. So we would bring that to the board for a vote, because we would be out of compliance with that resolution if it were to pass.
Janice, I just want to refine a little bit of what you just said. The assumption would be is we would implement the new lower minimum, and if there were a reason to keep it at the existing rate. So hypothetically, let's say the minimum deductible is $1,500. The new IRS notice is $1,500, and we're currently on a path where it's $1,600. The assumption would be, under the language of the resolution, if you passed it, that we would be implementing $1,500. We would bring something back to the board if we felt there was a reason to maintain it at the higher level. But the assumption is, the language says the minimum is what the agency implements. That is what we would implement, and in order for us to implement something different, we would bring that back to the board for your consideration and action.
Thanks for clarifying that, Dave. All right, so that was the follow-up from earlier this month's meeting. If there are no questions, we can go on to the resolution language. And so before I turn that over to Chair McDermott for the vote, I did just want to cover some stakeholder feedback here. We received one comment back, no concerns with the proposed resolution, but what you will see that changed in this language is that earlier this month, the very tail end of this paragraph, it said without action from this board, but we did remove that because we didn't feel that it was necessary. It was duplicative. And I did also want to mention that the said board did vote on this last week and they approved it. Chair McDermott, would you like to take it from here?
All right. We're going to take a vote on Resolution PEB 2023-04, UMP Consumer Directed Health Plan IRS Minimum Deductible. We should see how long we can make a title. This might be the record. Resolved that for plan years beginning on or after January 1st, 2024, HCA shall set the annual deductible for the UMP Consumer-Directed Health Plan at the minimum annual deductible level established by the Internal Revenue Service to qualify the plan as a high-deductible health plan. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Are there any comments from the audience? Seeing none? Any comments from the board? Seeing none? This is going to be a roll call vote, starting with Tom.
Yes.
Harry?
Yes.
Elliot?
Yes.
Monica?
Yes.
Kurt?
Yes.
And Michaela is out, and Lou, yes. Resolution PEB 2023-04 passes. Back to Janice.
Thanks.
Or Janice. Sorry.
Thanks,
I
Chair
was just going to
McDermott.
say you can't teach an old dog new tricks. It's so true.
All right, so now that that has passed, we have a few upcoming next steps that we're going to focus on. We'll be making updates to our member communications for HCA. We want to prepare for open enrollment coming up so that members are very aware of what's changing. We'll need to make updates to Regency's member website and their communications as well. We will be sending out new ID cards. A couple years ago, there was a federal mandate that the deductible and out-of-pocket limit needs to show on the face of those ID cards. So we'll need to make that change as well. And because of how the CDHP is set up, it's a combined medical and pharmacy deductible. So we'll need to work with Washington State RX Services, which is the pharmacy benefit manager for UMP. We'll be working with them to make sure that their systems are updated as well. But we'll be making lots of member outreach to make sure folks are aware of what is changing for next year. And that is the end of that presentation.
And you're up again.
I am, yes.
And this is regarding the UMP COVID-19 over-the-counter test coverage.
All right, so good afternoon again. I'll be presenting on this resolution today for over-the-counter COVID test kits for our UMP plans. So going into unwinding the public health, the public health emergency, the PHE, Kaiser and UMP temporarily expanded our PEB benefit coverage to make it easier to access the care members needed during the pandemic. But that federally declared public health emergency ended May 11th last month, and our plans have transitioned back to mostly standard coverage that you see on screen here. So a couple of those bullet points: treatment costs are still covered as a medical expense, COVID-19 tested, that will revert back to standard plan benefits, which could include cost shares. Over-the-counter home test kits, those were covered through May 11th, but those have no longer been covered for the past 6 weeks or so. And HCA, prior to that point, and both Kaiser and Regents, and we made very comprehensive outreach to our members, making sure that they were aware of what was changing in advance of that May 11th date. Going on to the next slide, we'll cover specifically for UMP. So during the PHE, OTC, over-the-counter COVID-19 tests were required to be covered with no member cost share. Since the PHE ended on May 11th, we made sure to mail notification letters from Regents that went out in advance of that. On that third bullet, you'll see what changed after May 11th. So going back to resuming paying the standard rate for all covered COVID-19 services. And under that last bullet, you'll see that the 2023-2025 biennial operating budget, which I believe has been briefly covered by Tanya in the past couple of meetings, what was in there. But there was coverage for 2 over-the-counter COVID-19 tests per member per month without cost share beginning July 1st, which Dave mentioned is this Saturday. So that was passed by legislature, which leads us into the resolution on the next slide that was brought up earlier this month. But before I turn it over to Chair McDermott for the vote, I did want to just cover some of the stakeholder feedback that we received. There was no concerns with this proposed resolution that we saw, and also similar to the CDHP resolution that I covered, we also removed at the end of the second paragraph here where it said without action from this board, because we didn't believe that that was necessary and it was duplicative. Also want to mention that SEB board voted on this last week, and they did approve that as well for the SEB UMP plans. Chair McDermott, would you like to take it?
Yep, here we go. Vote on Resolution PEB 2023-05, UMP over-the-counter COVID-19 test coverage. Resolved that beginning July 1st, 2023, all uniform medical plans will cover up to 2 over-the-counter COVID-19 diagnostic tests per member per month, up to $12 per test without member cost share. If the IRS issues future guidance that requires the deductible to be met prior to plan payment for over-the-counter COVID-19 diagnostic tests in high-deductible health plans, the UMP consumer-directed health plan shall be amended to comply with IRS guidance. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the audience? Seeing none. Any comments from the board? Seeing none, this will be a roll call vote, starting with Tom.
Yes.
Harry.
Yes.
Elliot.
Yes.
Monica.
Yes.
Kurt.
Yes.
And Lou, yes. Resolution PEB 2023-05 passes. Janice has a few comments to finish out the presentation. Back to you.
I don't have a formal slide on this one, but I will say that we have been working the past couple of weeks making sure that we have notification going out to members, because July 1st is Saturday. So we have been working the past couple of weeks. We're going to put up website alerts, send out notifications to members just to make sure that they are aware of this change and they can access that as soon as this Saturday. If there are no questions, that's it.
Any questions? All right, thank you.
Thank you.
Next up, pharmacy formulary development from FDA approval to plan coverage. Luke Dearden, clinical pharmacist in the Clinical Quality Care Transformation Division, is going to go over the PEB program's pharmacy formula development and how a drug goes from FDA approval to plan coverage. Materials behind tab number 6. Luke, welcome.
Thank you. Good morning, Chair McDermott and members of the board. My name is Luke Dearden, and I'm a pharmacist with the team. Today, we will be providing an overview of how newly FDA medications are placed on the formulary. And I do want to note that this presentation is not specific to any PEB plan in particular. However, its intent is to provide a general overview or general process that insurers use to evaluate drugs. Next slide. So the first objective is to describe the role of the U.S. Food and Drug Administration, or FDA, in reviewing and approving drugs. And then secondly, I'll explain how new FDA-approved drugs are then evaluated for formulary placement. And I outlined 4 major topics there that I'll be going over, and they're listed on this slide. Next slide. So first, I think it's really important to provide some insight into what it actually means when a drug is approved by the FDA. So if a drug is approved by the FDA, a prescribing provider or perhaps a member who's taking the medication can at least have a baseline level of confidence that the drug is safe and effective. And the FDA ensures that through a robust process that is designed to evaluate the risks and benefits of a drug. And they do that by they evaluate that a few ways. First, they analyze the target condition that the drug is trying to treat. They also review the benefits and risks found in the clinical trials done by the manufacturer. And then if there are any risks, they evaluate if those risks are able to be safely managed. And it's important to note that not all drugs are evaluated in the exact same way, though. For example, a drug that's seeking approval for diabetes, which is a very common disease state with a lot of alternative options, may be held to a higher standard in terms of safety and efficacy than a drug for an extremely rare condition that doesn't have any treatment alternatives. And next slide. In fact, certain drugs that aim to treat serious or life-threatening conditions may qualify for an accelerated approval pathway through the FDA. And these are often pretty high-cost drugs. For example, most cancer drugs are approved through the accelerated pathway. And as a condition of the accelerated pathway, these drugs are able to be granted approval through something called a surrogate outcome. And that's an outcome that may predict a benefit, but is not necessarily a clinically meaningful benefit by itself. So going back to a cancer drug, it may be approved based on that it improves a certain laboratory value. However, that laboratory value doesn't necessarily mean that it's going to extend life or even improve quality of life. And because of that, for these accelerated pathway drugs, the FDA requires the manufacturer to perform post-approval confirmatory trials intended to prove a clinical benefit. And so if the manufacturer doesn't prove that clinical benefit within an agreed upon time frame, the FDA does reserve the right to rescind approval altogether. Yes, Tom.
I read just within the last week that they've come up with it's gone through phase 2 clinical trials, a drug for Parkinson's disease that has some really very good results. And however, the FDA said it still has to go through phase 3 clinical trials. The people who have Parkinson's are fairly upset because they said by the time the phase 3 clinical trials are completed, we'll probably be dead. And so they want to know why the FDA can't either go ahead and allow after the phase 2 trials, why they can't go ahead and approve it on a trial basis. Does that ever happen? And is it always even, because they're talking even with an accelerated process, this drug's not going to be available?
I guess that's maybe more of a question for the FDA on why that particular drug is continuing on to a phase 3 trial, but depending on the particular pathway and the particular disease state, the clinical trial phase, and this kind of goes back to my discussion about surrogate outcomes, the clinical trial phase can be shortened in order to extend the drug to the general public if if it is determined that that drug's benefits outweigh the risks.
Are there other treatments for Parkinson's? Is that kind of
Yeah,
why it's falling into the other bucket
And
as
that's
opposed to?
also a consideration, kind of what I said about diabetes,
Right.
For sure.
I guess, let me see if I understand what you're saying. So let's say a drug is needed and they grant approval.
Mm-hmm.
And it was just in the clinical, not in clinical trials, but in the laboratory trials that this drug shows promise. Then the FDA approves it. And then the manufacturer has to do clinical trials on people.
So,
Is that what you're saying? I'm
no,
new to this.
to clarify,
Oh.
a drug always has to go through at least some type of clinical trial before it's approved by the FDA. What I was saying is that sometimes those drugs are evaluated based on, a surrogate outcome, which is an outcome that may predict a benefit, but does not necessarily guarantee a benefit. The FDA says it's reasonably likely to predict a clinical benefit.
Okay.
And sometimes that's necessary. I mean, trying to prove that a drug extends life takes a lot longer than just determining that it might improve a certain biomarker or something like that, if that makes sense.
Yes, I needed that help. Thank you.
Yeah, and that kind of goes into continuing on with my presentation. You can, do you have a question?
There you go. You're good.
So, just this discussion we just had, and I'm really happy for all of the questions that you're asking. It presents a challenge for payers. If a drug is approved based on this surrogate outcome, we have to be asking, does it really provide a clinical benefit, or was it based on something that may not provide clinical benefit? And we need to evaluate that for our population. And then just a note at the bottom of this slide that the FDA approval process, even in the context of accelerated FDA approval, can take many years, sometimes decades. And this is what is depicted in this diagram, which I would say is a higher level overview of the drug development and FDA approval process. So you can see on the left-hand side of this slide, perhaps thousands of chemical compounds will be identified in the research phase, but fewer and fewer make it through each phase to the preclinical trials, to the phase 1, 2, and 3 clinical trials, to FDA review, and then finally FDA approval. Go ahead.
I have a related question. What would you say the percentage of the approved drugs coming through, I don't know if I'm articulating this appropriately, come from university research versus drug manufacturer research? And this may not be a good question because it depends on the disease, it depends on the kinds of drugs. But I always hear competing claims I read that drug manufacturers say if we couldn't, if we didn't have the money to perform our experiments, you'd have no drugs. And yet, when I read about the history of diabetes and many other drugs, it was university research in more than one country that led to the breakthroughs.
Yeah, I can't answer that question specifically in terms of what percentage come from, academic funding versus, drug manufacturer funding. But I'd be happy to follow up.
Thank you so much.
And Monica, you have a question?
Yes, I do. Hold on. That's a very interesting question, Elliot, and I would just say that answer is going to be really complicated because universities that I've been affiliated with have joint projects and programs and institutes that do different kinds of research around drug development. So that's going to be a really tricky question to answer, but a very good one. My question is actually more relevant around the scope of the presentation that you're providing today. I am assuming, given what we saw around the emergency use authorization process, that you're starting from the beginning of the timeline and moving all the way towards approval and only bounding your discussion around that, or are you going to include emergency use authorization?
For the purposes of this presentation, I did not include emergency use authorization. This is strictly referring to drugs that were approved by the FDA.
So Monica, this presentation is about kind of the bread and butter process, the general process. We did not have the emergency use process, but to Monica's point, there is a separate track that is even more accelerated and has different standards and timelines that are applied that many of us, well, virtually all of us in this room experienced in the past couple of years related to vaccinations. And so if the board's interested in learning more about the emergency use process, then we can work on something to share about how that is and how it differs a little bit from the bread and butter examples that Luke's way through right now.
I would appreciate it.
My point of bringing that up was also for the public, right? Because I don't think we're really clear in science communication around the fact that, we're talking about drugs that have already been approved, as opposed to what the public also has been through around understanding the more accelerated fast track. So I'm just trying to make a distinction and make sure that's clear.
No, I appreciate that clarity, Monica, because you're right. As I just said, everybody experienced emergency use authorization in the past couple of years. Tom, you have a follow-up?
Well, just that question I asked about that Parkinson's disease, is that would that be a drug that would fall under the category that Monica just mentioned?
The emergency use authorization? Yeah. I don't believe so because there are, like Lou pointed out, there are other treatment options available for Parkinson's currently, and it's not in an emergent situation in the same way that something like COVID was, if that makes sense. And just, Monica, to clarify about the emergency use authorization, the FDA's process will be different than what I have just described. However, much of what I'm going to describe in the rest of this presentation, where the plan is, or the health plan is evaluating, giving that drug a clinical evaluation, would still apply potentially to a drug that went through the emergency use authorization pathway. Just to clarify.
Mr. Chair. Is there any kind of sign-off requirement for a member that wants to participate in a clinical trial of a new medication?
What do you mean by sign-off?
In other words, if I wanted to participate in a clinical trial and I was accepted for a new heart medication that dealt with congestive heart failure, do I need to get anyone's approval to use that medication as a member of the plan?
Oh, as a member of the plan?
Yeah.
For Uniform Medical Plan, at least, you are able to participate in a clinical trial if you meet the requirements for that specific trial, but it's not up to the plan to determine if you meet criteria for that specific trial. That would be up to the sponsor of the trial, which could be a drug manufacturer or an academic institution of some kind.
Okay, thank you. I'll go later on, I'll talk to you more about that.
Okay.
Thank you.
Okay. So back to this drug development slide. I pointed out mainly because it's important for us as payers to understand, at least in general, the overview of how drugs are developed and approved, because it's an important part of our process in terms of monitoring the pipeline. And that brings us to our next slide here. So pipeline drugs are expected to be reviewed by the FDA for approval at some time in the future. So these are drugs that have not been approved yet, but they're potentially expected to be approved. And monitoring the drug pipeline is important for payers so that they can anticipate how new products will affect the health plan. And we do this in a variety of ways through a variety of online resources. We also have meetings directly with drug manufacturers as well, so we can better assess their products and also their timelines and the clinical evidence as well. And then after FDA approval, plans typically determine coverage of a new drug within 6 months, I'd say, although often coverage is determined more quickly than that. Next slide.
I have a question.
Yep.
Do you also, so when you're saying you're saying HCA meets with drug manufacturers?
Correct. Yes, we do have a regular process to meet with drug manufacturers. A lot of that is more specific to the Apple Health Medicaid side.
Okay.
However, MODA, who's our pharmacy benefit administrator, also has a process where they interact with manufacturers as well. And
What-
it's
I'm
go
sorry.
ahead.
Why don't they meet with universities who also are involved in this process? Or is it because they don't manufacture the drug and they don't have the final result?
Yeah, I think
Yeah.
that's part of it. I'd be
Yeah.
happy to follow up on that question.
Yeah, thank
But
you.
when it comes down to it, the bulk of people who are actually marketing the product is going to be the drug manufacturers, and they're often going to understand, the timelines as far as FDA approval, when they're going to come to the market, and that's helpful to us just so we can better prepare for the launch of their products.
Thank you.
Yep. So before any further evaluation begins for a drug, we need to determine if the prescription or if the drug is even eligible to be covered by the plan. And this is going to differ from health plan to health plan, but these bullets are just an example. So first, usually it must be a prescription drug or product that's approved by the FDA. It can't have an over-the-counter alternative, usually. It can't be a vitamin, dietary supplement, or homeopathic drug. It can't be an excluded product by the plan, and this will also differ from plan to plan, but for example, UMP excludes drugs indicated for cosmetic purposes, sexual dysfunction, and weight loss currently. And then it also must be obtained legally, basically meaning that it's dispensed from a licensed pharmacy by a registered pharmacist. Next slide.
I do have a question.
Yep.
So UMP, and we are specific to UMP here, they do not cover drugs that are used for weight loss. With the onset of Ozempic and Wegovy, that is introducing a whole new strain of weight loss drugs that are specific to weight loss. although Ozempic was originally for diabetes, but they discovered that the semaglutide has a function that is really good for obesity. But then what I see is that within the next 6 months, there are going to be a whole raft of new obesity drugs that are coming out. I think there's like 5 or 6 more that are going to be even more powerful than Ozempic and Wegovy. Is there a chance that UMP would consider those drugs, some of those drugs, once they know just how effective those drugs are in handling obesity? Because in my research, it said that obesity is one of the 3 principal causes of cardiac disease.
Mm-hmm. Yeah, that's a great question, and we are very well aware of Ozempic and similar drugs to treat weight loss, and that is being evaluated currently at the agency. But yeah, I appreciate your point.
And Tom, I'll just add, we talk every year, and in fact, a little later today, John Parton will remind us all of the kind of cyclical nature of the work, and when we, the royal we, many of us are in the authorizing environment, that includes the legislature, the governor's office, the board, the agency. There's a lot of implications. That's an example of something that goes through the benefit review cycle for possible changes. A lot of the equation is what are the impacts on the funding rates and the premiums and the state's contribution for employees, and so there's a whole host of aspects to that. But you're correct that obesity has a lot of relationships with a lot of comorbidities in some of our highest cost disease states that aren't unique to the Uniform Medical Plan and aren't unique to the state of Washington. And so it certainly is kind of the topic that I think everyone will be talking about with these drugs. The conversations have already begun. The lobbying by various industries about seeking coverage from payers is certainly, will be widely discussed in every state's legislature in their next natural cycles. So yes, it's certainly something that is very clearly going to be up for discussion.
Yeah, thank you. So after a drug is at least eligible to be covered by a plan based on, the baseline requirements, it'll undergo a clinical evaluation. And almost all health plans or insurers use a pharmacy and therapeutics or P&T committee to evaluate drugs. And a P&T committee consists of medical practitioners and pharmacists, and their primary responsibility includes a review of the clinical trials and also comparative effectiveness reports, if there are any, and the FDA-approved prescribing information. They consider current guidelines and the drug's overall place in therapy. They consider specialist feedback often and other patient experience. And then sometimes, although not always, they will review the drug's cost as well and other relevant cost information. And a P&T committee, depending on the plan and the situation, may specify exactly how a drug needs to be covered by the plan, or they may just say that it's simply eligible to be covered by the plan. And then also they oversee quality initiatives, typically designed to improve either cost or clinical outcomes. Next slide. So to drive this point home a bit further, and I think this is an important point, the P&T committee evaluation in many ways goes beyond the scope of FDA approval. And so they're asking some questions that the FDA doesn't necessarily ask. And a couple examples of these questions are, how does the new drug compare to other similar drugs? Where is the drug's place in therapy? Is it first line for the disease state? Is it second line, or is it fifth line or beyond? And then perhaps most importantly, and going back to our earlier discussion about drugs that are approved via the accelerated pathway and using surrogate outcomes, they're asking, does the drug provide a clinically meaningful benefit? Or was it approved on maybe a questionable outcome where the plan is paying a lot, it's an expensive drug, but it maybe doesn't have really any meaningful clinical benefit? And given the complexity of this review, it's entirely reasonable that two different committees or two different insurers may reach different conclusions on how a drug should be covered. Next slide.
I have a quick question.
Oh, yep.
I get notifications from the P&T committee. When you attend a meeting, and I must confess I haven't, do they discuss these things in public?
Yeah, and I'll get to that in a couple of slides.
Thank you.
But the short answer to that for UMP, at least, is kind of. But it depends what P&T committee you're. But I'll get to that.
Thank you.
Elliot, you'll appreciate this as a lawyer. It depends.
You've outed me.
Yeah, Law 101 there. The Law 101.
All right, any other questions? All right, great. So after the clinical evaluation, a drug will undergo a cost evaluation, and the cost analysis process is really secondary to the clinical evaluation, and it aims to determine which mix of drugs in a certain drug class would be most advantageous to prefer. And it's important to note here that a drug isn't just, it's usually not evaluated in isolation. The cost of the new drug would be compared to the cost of similar drugs, like drugs that treat the same disease state, for example. And it's also a complicated process. We're not necessarily just looking at the cost of the drug by itself. There are other factors, including a drug's actual or expected utilization we factor in. What's the net cost of the drug to the plan? And this factors in any manufacturer rebate opportunities. We factor in member experience or member disruption, for example. There are clinical considerations. For example, is one drug superior in terms of effectiveness, or does it have more indications that could justify a higher cost? And then there are also market factors as well. For example, is there a generic available on the market currently in this drug class, or will there be a generic available in the future? And if so, it might be worth directing utilization to the drug that is going to have a generic entrant at some point in the near future. And next slide. So this is basically the implementation phase. So formulary placement or preferred status is finalized after clinical and cost evaluation. Utilization management or strategies may also be implemented as well. And a couple examples of strategies where we've discussed these before in these meetings are prior authorization, quantity limit, or step therapy. And then the pharmacy benefit manager, or PBM, implements drug programming, which is applied at the point of sale or the pharmacy. And that's where the appropriate cost share is applied when a member goes and picks up the drug from the pharmacy based on where it's placed on the formulary. And then any applicable strategies are also applied at that time as well. Next slide. So, how does UMP decide which drugs are preferred? So this is specific to UMP. However, we use the same overall strategies that I discussed, both the clinical evaluation and the cost evaluation. And so drug classes listed on the Washington Preferred Drug List or the Washington PDL are reviewed by the Washington State P&T Committee. And Elliot, to answer your question, Washington P&T Committee meetings happen every other month, typically. I believe the next one is going to be in August, and these are open public meetings that you're welcome to attend. After the Washington State P&T Committee provides a recommendation, staff at Healthcare Authority conduct cost analysis based on those recommendations, and then preferred drugs on the Washington PDL are also preferred on the UMP PDL. So there's some coordination there. Drug classes not on the Washington PDL are reviewed by the Washington State Prescription Drug Services Committee, P&T Committee. And to further answer your question, Elliot, that's also known as MODA's P&T Committee, and those meetings are not open to the public.
Thank you.
Yep. And so MODA, based on the committee's review and also MODA's cost assessment, will recommend drugs and whether they should be preferred and what utilization management strategies should be applied. And then HCA reviews MODA's recommendations and typically approves MODA's recommendations. I'll note here that UMP is pretty unique in the sense that it employs two separate P&T committees, and that's based on legislation that requires UMP to follow the Washington Preferred Drug List process. But I think it's also a testament to how two different P&T committees can make different determinations, and that's one of the reasons why the UMP Preferred Drug List is not identical to MODA's Book of Business Preferred Drug List.
I have another question.
Yep.
I've been reading a lot about PBMs recently, and of course what I'm reading is from the private market, and it looks like Halloween stories about how PBMs get these incredible rebates and manipulate. I'm assuming that that has nothing to do with our process because we're a state agency, that MODA operates a little differently.
Yeah, that's correct. We do factor in, and also MODA and HCA do factor in rebates that we are offered. However, those rebates are not kept by MODA. They're passed 100% to the plan, UMP, which then goes to lowering premiums. So
I think that, just for future reference, that is a very good point to make because at least I, as a board member, didn't have access to that information. And sometimes when you're reading all of these scary articles, you don't really know how to differentiate. Thank you.
Oh yeah, no problem, and I'll note that comment for the next time I give this presentation.
Yeah, I just have a comment, suggestion. Maybe it's a little early, but maybe for somewhere down the road, like January or retreat, we could invite MODA to speak and talk a little bit more about their role, what they're doing for us, how we interact, and those kinds of things, because of a lot of factors such as COVID and other things, not being able to meet in person. I haven't really noticed a presence by them, and it's been a long time since they've had the opportunity to come in here and tell us a little bit more, and so I think that would give us the ground level, some answers at ground level that that aren't here, that I'm not expecting you to do, that's really their realm. So
For
again,
sure.
it's just a suggestion.
Yeah, I appreciate that, and I can assure you that representatives from MODA have already taken note that you said that because they are listening.
That's a good point, Luke. We have an expectation, before the pandemic, you literally saw most of the vendor carrier partners for life insurance, LTD, medical, dental in the audience. In our hybrid status, they generally are virtual. So I just it's a good point to remind everyone that I think we have almost 100 people on. Oh, I was just guessing, but we are actually literally at 100 people that are on the call, and it includes, HCA staff, members of the public, our vendor partners on various lines, and TVW, of course. So, Elliot.
Yeah, one of the questions we get a lot at RPEC are about PBMs.
Okay.
And it's another good plug. The chair always says this at the beginning of our meetings, that if members of the public have questions, they can submit them to staff. I guarantee you by the time Luke gets back to his desk, MODA will already have emailed him some insights about the questions that are related to the pharmacy presentation, because our partners are very good about reaching out to staff to help them answer your questions at the next board meeting as well. So there's a lot of real-time things happening here.
Yep, that'll definitely happen. So. All right, so I'm wrapping up here. Next slide. So really the final phase, and this isn't necessarily how new drugs are placed on the formulary specifically, but I just wanted to note that drug classes, basically all of the drugs on the formulary or drug classes are reviewed on a regular basis. Typically that's every year at least, especially for new active drug classes, I would say. And this ongoing review may lead to formulary adjustments. And what's included in this review will again vary, but these are just a couple of examples I have listed here. So prior authorization approval rates. A lot of people don't realize that in addition to PAs being a burden and using resources for members and providers, PAs also use up resources for health plans and PBMs. So if there's a more efficient way to manage that drug, we're very happy to evaluate that. Let's say a certain drug has like a 100% approval rate. We're going to most likely evaluate that and try to come up with a more efficient strategy. There's ongoing cost monitoring. Drug costs change quite regularly. We do something called retrospective drug utilization reviews, and that's really simply just making sure drugs are being used appropriately within the plan. And then we are also assessing, mostly MODA, by the way, is assessing new evidence or guidelines, have standards of care changed that need to be reflected in our formulary, for example. And then finally, there's one more slide here. And this doesn't necessarily have a ton to do with the presentation. However, I thought it would be helpful to share how a Medicare Part D formulary may differ from something like a uniform medical plan formulary, or at least their requirements. So a Part D formulary requires coverage of all of the drugs in the protected classes that are listed on this table. Additionally, a Part D formulary requires that at least 2 drugs in each class are covered. And then finally, and maybe one of the biggest differences between a Part D formulary and something like a UMP formulary is that there are pretty strict limitations to mid-year formulary changes for Part D formularies. And they're limited to, obviously, they can remove a drug from the formulary if the FDA has determined that it's unsafe for use. And then also, they can remove a brand name medication from the formulary if a generic equivalent enters the market. But that's pretty much the extent of mid-year formulary changes for a Part D plan. And with that, I believe I'm done, and I'd be happy to answer any more questions, or maybe everyone's already asked their questions.
Any additional questions for Luke?
Just one comment. That was very good, and I really appreciate all the information you gave us. That's kind of what I was looking for to begin with. So thank you.
Yep, we tailored this presentation specifically to you, so
I'll just say, Tom was the inspiration for this presentation.
Thank you, Tom.
Got out of it too.
All right, thank you, Luke, appreciate it. Next up, we have Michelle George, Communication Manager from the Communication Division, is going to provide an overview of the open enrollment member communication survey conducted this past winter. Her materials are behind tab number 7. Welcome, Michelle.
All right. Chair McDermott, members of the board, good morning. My name is Michelle George. I am the Communications Manager for Employees and Retirees Benefits, and I'm here to present on the Open Enrollment Member Communication Survey that we did earlier this year. Next slide. So why did we conduct a survey earlier this year? We know that our PEB and SEB programs provide several communications for open enrollment, including our newsletters, our web content. We have both in-person and virtual benefit fairs, as well as emails and webinars that we do. However, our newsletters that we put out in October are the primary open enrollment notice to our members, and we want to make sure that we're using continuous improvement to make sure that we're meeting our members' needs. Next slide. So how do our PEB and SEB members receive the newsletters? We are sending them via mail or email if they've signed up for the email subscription service. We also post the newsletters on HCA's website. We promote them via social media like Facebook or Instagram. And we also provide them to our employers as forwardable messages with links for the employees. Next slide.
Quick question. When did you say the newsletters go out?
The newsletters went out February 22nd through March 17th of this year. So about a little over a 3-week period.
Great, thank you.
You're welcome.
Michelle, you just said February. Did you mean?
February 22nd through March 17th of this year.
Okay. Sorry, I misunderstood. Maybe I misunderstood the question. John, I think it's helpful to know we send newsletters at 3 different points in the year. February, May, and October. And so I wasn't sure if you were asking about open enrollment or the most recent.
That's what I was concerned about. Yeah, I
Okay.
thought that was kind of early, but no.
Okay.
Oh, okay.
That's where I thought I was hearing a disconnect. So,
Decided some stuff.
Yeah.
Exactly.
Yeah.
That was my concern.
so there's 3 points of the years that we send newsletters, and the open
Yeah.
enrollment one is in October, but
Right, but-
February and May.
But the survey was done after open enrollment.
This last year.
Right. So this was an online survey. Our primary focus was on our October newsletters, but we also asked questions about the February and May newsletters. We also asked questions for UMP members so they could respond to their open enrollment communications. And respondents could also answer additional questions about other open enrollment communications that we provide. Next slide. So how did we promote this survey that was released in February? We included an invitation to participate in the February PEB and SEB newsletters that were sent via mail and email. We also created forwardable messages that were shared by the benefits administrators. Those are our payroll and benefits office staff in the agencies and districts. We also shared them with unions and associations, such as the Retiree Association, so they could invite people to participate. We promoted the survey on social media, And Sue Birch also sent an email to agency directors asking people to participate. Next slide. So you can see from the two pie charts here, a comparison of the survey respondents on the left pie chart versus our total PEB and SEB population on the right pie chart. As you can see in these two pie charts, survey respondents, the public employees and retirees were overrepresented in the survey compared with school employees and our continuation coverage members. So almost half of the survey response were public employees and 22% were retirees.
Michelle, I realized, how many responses did we have?
2,390 responses total over a little over 3-week period. Okay, next slide.
What was your,
Yeah.
was there a goal, that 2,300 or whatever it was? I mean, when you went into this, was there a goal that you hoped for?
We did hope for a few thousand based on earlier surveys that we've done. We have received anywhere between 2,000 and 4,000 responses, usually for a 3-week period. So what did the survey tell us? What we're doing well is we know that HCA is a trusted source of information for our members, and our website is a widely used resource across all member types. With our newsletters, our respondents are reading at least half or more, and for the October newsletter, it's overwhelmingly people are reading it cover to cover. And the respondents feel like the newsletters are understandable, user-friendly, and provide just the right amount of detail. Next slide. So the respondents told us, where could we improve? We can make the information that we already provide easy to find and let them know how to sign up for the email delivery service. That was an overwhelming choice of how people wanted to receive their information. We can also promote health literacy and awareness of the benefit offerings and how the benefits work. And we can improve using website usage data to put our resources toward where members are finding the information. We have lots of information on our website, and sometimes it's easier to find in one place rather than another place. Next slide. So here's what we're already doing based on survey responses. We're working to improve our health literacy for our members. We launched on May 15th HCA News, which is a new web page that provides more in-depth information on how benefits work, more details than what we can usually provide in our newsletters due to space considerations. Our newsletters are also including some health literacy articles. We included information on hepatitis C, burnout, smart health, and the activities that people can participate in. We're also getting more member feedback, as you've seen this year. So besides this open enrollment member communication survey, the HCA conducted 24 retiree listening sessions and public forums total. We also have a website feedback survey that members can participate in to give us feedback. Next slide. So what are our next steps based on this survey? We're using the feedback to improve our current materials and make more member-specific communications. So we want to make sure that we're providing information on how members can prepare for retirement. That was a big feedback that we heard from our members. And we're also going to be preparing retiree versions of all PEB newsletters, not just the October edition. So for those of you who are PEB members, we already do 2 or 4 versions of the October newsletter, but we do general editions for February and May. We're going to be doing retiree versions for February and May as well. We're also going to be improving our newsletters by focusing on topics like how benefits work, how to use them, the costs, changes, in addition to what we already provide. And we're going to continue to seek member feedback for continuous improvement on how we can improve our communications. Next slide. So any questions about the survey?
Yes, just a suggestion, even though I suspect you've already thought of this, on the retiree communications, what we often hear in RPEC is to keep paper versions coming because, and I confess to this too, I'm not a web expert, and a lot of older people don't even know how to use their computers. So unfortunately, snail mail is the only way to reach them.
Elliot, I can assure you that while I'm the director, we will not be getting rid of paper, whether that's newsletters, forums, et cetera. We know that there's an important balance of needs for both paper and electronic, and giving people the preference. That's why at this point we have a select opt-in process for electronic pieces. But we know that there's a strong importance and preference for some people, myself included. I like getting certain things in the mail and being able to balance that. One of the challenges we have, though, is you did call it snail mail, and the predictability and speed at which information gets in snail mail versus electronic, there is a real difference there. And especially that rears its head in topics like provider network disputes and trying to get information out about that, where a snail mail letter, by the time it got to somebody, the information is very likely out of date already. And so there's a balance there. But for the key communications like newsletters and things like that, we will continue to support paper and snail mail.
Tom, you have a question?
Yeah, I just was, well, first of all, I think the outreach that we've been doing this year has been a very positive thing, the listening sessions and public forums, and I'm wondering if you're going to, the plan is to continue doing those next year.
I will take that one on, Tom. Director Birch and I talked about this a little earlier this month, and there was a commitment made in a response that Sue provided to the Medicare Coalition that we're working on, that we have seen a lot of value in the listening sessions. And so we're going to identify in our cyclical work, I talk about our cycles of work, where's the best time in the year to have a dedicated time to do listening sessions, not just with retirees, but also with employees. We serve a lot of different populations. The listening sessions this year we're focused solely on retirees or those who serve or represent on or help retirees or maybe transitioning into retirement soon. But we are going to be identifying where in our cyclical process that the feedback would be most timely, that we can balance trying to get information that will be more, we'll be able to react to. So that's the long answer of, we will be having this as part of our main staple work in our cyclical processes. We're still evaluating where the best time of year is for that.
Okay, thank you.
One of the things I've heard from the retirees is they would have liked a longer period of time to have these listening sessions.
And Elliot, that's why we talked about, or Director Birch wanted to make the commitment, and I do too, to finding the time to have that as part of, it's a continuous. It's not just you talk to people in 2023 and then you don't talk to them ever again. There's a kind of a cycle that needs to happen in making sure that we're incorporating and interacting with members. And at the same time, for the current scenario that we were trying to address, which was working on getting feedback related to last year's conversations and then leading up to a legislative report, there does have to be a finite time for that project, if you will. It doesn't mean that there's not an interest or desire to continue having those engagements, and that's why Director Birch and I have made that commitment that we will find a time for that in our cyclical work as an ongoing commitment and essentially new permanent work stream within our activities of the division.
Thank you.
Other questions or comments?
Yeah, I have a question. Did the survey instrument measure the benefit fares? Were any questions asked about that? And
Yes, if people did attend the benefits fairs or not among the survey respondents?
well, the value of them or the content. Did you get any feedback relative to availability? What was presented, how it was received or not received?
Not as far as that level of detail. It was whether people attended or not.
Other questions? All right. Thank you, Michelle.
All right, thank you.
We're going to go ahead and long meeting, so we're going to take a break. We're a little bit ahead of schedule. We'll call it.
A little bit behind. Oh, no, no, you're right. We're 5 minutes ahead. I'm sorry. I was just sitting here counting, and I was like,
I was
we're
like,
behind, we're behind.
I don't think we're.
Calling out in public.
So why don't we? That's all
Telling
right.
everybody today.
Why don't we come back at 10:25? All right. Thanks, folks.
My apologies, Chair McDermott.
What do you think, Dave? You want to get rolling?
I thought we were behind, so yes.
So you're like, I'm in a different time zone. All right, folks, we're going to get rolling again.
Oh, yeah.
Is John going to be virtual? All right. John Parton, Benefits Strategy and Design Section Manager in the Herb Division. We'll start calling you the Herb Division. That's a mouthful, so that's easier. Is here to give us an overview of the multi-year cycles for PEB program benefits work and some of the factors that influence decision-making and implementation timelines. John's materials behind tab number 8. Welcome, John.
Thank you, McDermott. Members of the ensure and a level set and then, as you mentioned, the timelines and the factors that influence those and kind of determine how a benefit gets identified and implemented and developed. So if we could go to the next slide. This is just showing there are a number, this is not all inclusive, but there are guide and help influence development to existing benefits. And as you can see here, some of those are the board itself, the members and representatives of labor, the legislature, the executive branch, and the federal government are all involved as well to varying degrees on any given benefit. The important piece here is the piggy banks in the middle, right? And that authorizing something identified as worth pursuing, execute on it and implement it, road back budgets and the thing that federal government has some influence on obviously the product and the benefit, and that can be direct in that budget piece as well. But generally, it's the authorizing environment here in the state that we're talking about. So it's not just at the points when we're developing budget, we're still getting input from each stakeholder, particularly the legislature in this branch, about things that we should be considering. And as we identify ideas, they're also giving us input and feedback as each of the other stakeholders we typically try to gather feedback and input from as well. So multifaceted, and everything leads back to, at the end of the day, we've got to have the funds to actually implement and execute on these ideas. So if we can move to the next slide. So this is the first cycle that I want to cover. I think the really important part as we go through these two slides, many of you have seen them before and they detail the entire process, is from the we identify an idea development when it goes through fermentation process. And will take 18, 24 months. And the other piece that I'd like to kind of and revisit it after we review both of the cycles is that when an idea comes up matters. It kind of helps determine when we can actually implement. If something comes up at the beginning of this 4-month cycle that's then it starts when the typically the legislature getting development of the operated is only in session and into a certain year. And so it becomes really critical that we have the ideas, points in time, components occur so that we can get them in front of the folks, the decision makers, get input and hopefully approvals that support the ones that we're going to move forward with. So keep that in mind for a moment. We'll come back to again when it comes up, when the idea occurs, it helps determine when something can be implemented. But this first one is looking at contracts that we with authority hold. These are things that, like with a informal plan or some of the insured products that are offered. That renewal things, what have we seen or heard in the last year or 2-year cycle, depending on which one of the contracts we're talking about, and what kinds of changes would be helpful and desirable at the next renewal. And as we kind of march around on this timeline, we're doing the last renewal here, and I apologize for acronyms, and I know I've been criticized for that many times. If I use too many, feel free to stop me and ask for some detail as to what they mean. But that RFR is a request for renewal. We're sending it out to that payer partner or that vendor with kind of here's what we want to see in the upcoming renewal, and then respond with ideas that they have from what they've been seeing in experience, the claims experience, things like that, both specific to, in this case, public employees that are insured through healthcare authority, as well as their other relationships, other employer groups or members that they cover. And they'll give us ideas that might be very specific to public employee coverage, or again, comes from that wider across their term book of business, all of the members that they cover. So that then comes back in, we review those, analyze what of the suggestions that we gave to the contracted entity, did they respond to positively? We have some discussions and some negotiations. What we need to see. We also review what they suggested as things that we might want to also consider. And that continues to move around where I think geared towards kind of that early summer, we need to have our discussions with the board so that you know what we're contemplating. You've had a chance to provide input because some of these are going to require board decisions and votes ultimately. And we're geared towards a July submission for development of the decision packages. Those decision packages kind of weigh the pros and cons of each of the proposals, the financial impacts, what's it going to cost to make the change, what's it cost to maintain it over time, and what will be the benefits, not just financial, but in terms of member experience and member outcomes. And that those packages are used to guide the development of the operating budget. Typically, we see the first pass of the operating budget towards the end of the year, early in December. That comes from the executive branch. And then there's a reconciliation that has to happen with the legislature. And so once we get those combined reconciled budgets, which happens shortly after the first of the calendar year, we then know what we have funding for, what's been approved, and what we can move forward in implementing. And we start that implementation process. Any board approvals and votes or inputs, guiding inputs that are required would happen after that. And then ultimately, it's the first of the following year. So we now spanned a 1-year period getting through that, getting the idea, getting through the request for renewals, generating the decision packages for development of the operating budget, getting those approvals and the budget appropriated for the proposal, and then planning for implementation in the following year. So again, that's why this is taking an 18 to 24 month period. And some of these, again, just to put a finer point on it, are very specific points in time that they have to occur, like the launch for the plan year, and the development of the budgets and the approvals, and then the associated conversations, right? Whether it happens external to the agency with various stakeholders, or the interactions with you on the board and members of the public that communicating the change as it's rolling out. So the one other difference here before we go into the benefit planning cycle, which is how we generate new ideas and innovations, this one again specific to those contracted entities that we have relationships with, is that this is usually 24 or 12 months sooner in implementation time frame. Both last 18 to 24 months, but in these examples, which were from this year's cycles, this process would have been looking for 1/1/2024 implementations, and started back in the summer of last year. I'll pause there for a moment. There's a lot of information, as always, packed into that. If there are questions, or we can wait till we go through the benefit planning cycle to compare and contrast a little bit. But any immediate questions to any of that?
Any questions for John?
John, before we move on to the next slide, and it gives everyone an opportunity to raise their hand, there's another thing. I'm thinking about other questions that I've heard in the past couple of months and past year, and I realized that this is actually a good slide to highlight this topic. A question will come up is, can something be discussed at the board earlier than it is? Is there an opportunity for more notice or more conversation? And the challenge that we have is nothing's impossible, but it changes the potential implementation timeline. And so we often are bringing things to the board and talking very purposefully in May and June, because a lot of it is contingent on the legislature having just left town. And the legislature leaves town in March in even years, and April in odd years, unless they're special sessions, in which case that's when we tend to have board meetings that go into late July and sometimes early August. So there's a contingency there, and we can't do certain mechanisms until decisions on the operating budget or the supplemental budget have been made. So in that sense, there is that fixed point in time where we can't begin those conversations. Sometimes we can anticipate and we try to lean forward, but we can't get over our skis too much. A great example is the hearing aid conversation and the resolutions that were part of the board this season. There was a bill that was going heavily full steam through the legislature, but we also couldn't bring you action that was related to that legislation until a certain point in time, specifically after the governor acted on legislation that had passed the legislature. We actually leaned right up on the edge of that by presenting a resolution after the bill had passed, before it was acted on by the governor, because we want to honor the strong tradition and policies of this board to have something introduced at one meeting but voted on at a subsequent. So we introduced it while it was still pending action, and then scheduled your vote for after the governor acted on the bill. And that way, whatever happened with the governor's action on that bill could have changed the course of what the resolution was ultimately, but we were trying to tee things up. The main point I'm trying to highlight is there is a very deliberate process, and these timelines get to be very short. We're really talking after the legislature adjourns to you bringing you rates publicly. That's really a 60, sometimes if we're lucky, 75-day period. That's multiple engagements and negotiations with the carriers. We're having multiple board meetings. We're talking in executive session about how the rate development is going and some of the levers that are there that are proprietary information. Though that is what guides when the conversations happen, and we do our best to try and balance those different needs, but we really are kind of bound sometimes by the fixed points, like the beginning of a plan year, the legislatures in town needing to have certain decisions by the board in order to be able to host open enrollment and get information out. So there are really tight timelines. And to John's point, he said this a couple of different ways. The way I say it is, you can have the best idea in the world. Coming up with that idea in May is very different than November. And then if you came up in November, it's still a great idea and it still may be implementable. But if you come up with in May, it has a completely different implementation timeline than it does in November. And so there are a lot, that's why we try to emphasize the cyclical work that we have here at the agency, because nothing's impossible, but when the idea comes up, strongly can indicate what realistic timelines are possible for that great idea. And now I've generated a question from Elliot, John.
Just a quick question. There was so much packed into this. I couldn't wrap my brain around it totally, and probably I still can't. But I think John referenced two different kinds of budgets that affect the benefits. I know it's the operating budget, but was there another one? I thought he mentioned something, but maybe it went by so fast that... Supplemental.
Yeah, I think
Okay.
I think that would have been me accidentally saying that, Elliot. Every legislative session, there is part of the
Okay.
budget that's looked at. In odd sessions, it's all the operating budget, but in a
Okay.
short session where they're making refinements to the big policy ideas, they make the grand big ideas generally in an odd year when they're setting the biennial budget. And then when they're revising that budget, it's the supplemental budget process is what it's called. But it's all part of the operating budget for the state.
Okay, so let's say somebody comes up with an idea and PEB votes on it this year, and there's no money for it, then it would be subject to funding by the supplemental budget process next year. Is that making sense?
That is making sense, but I would say the order of events and how it traditionally goes is the legislature discusses the funding aspects before. It's usually not the way it's usually not the board before the legislature, it's usually the legislature before the board.
Okay, got it.
Yeah.
Great call. And as Dave said, just to again cast it a slightly different way, if we have a really good idea but it doesn't happen ideally at the ideal time within the cycle, depending on when it does happen, there's some latitude. We might still be able to make it happen within the current cycle. But if it happens too late into that cycle, we've already missed some of those fixed points in time, particularly those around the development of the operating budget. Or the plan year open enrollment is another really good call out. If we've missed those or we're too close to them, it's almost impossible to make it happen, or at least to make it happen effectively for that plan year. And so then we'd be pushing it back into the next cycle. So all things that typically we're looking at, trying as best we can to make sure that when someone has that aha moment, we have a really good idea, we can get it implemented as quickly as possible, but we've got to work within those processes and the parameters that are kind of set for us from a time frame perspective. So if we go to the next slide, this is the second of these processes. This is what we're actually looking at sometimes modifications to an existing benefit, but also we're trying to generate completely new, innovative ideas, things that we should be thinking about and considering. Great example here to kind of illustrate between these two processes. We talked earlier about weight loss medications, and weight loss medications in and of themselves have come up in both of these processes over the last few years. But when we think about something more holistic and strategic than just the weight loss medications, but a holistic weight loss or weight management program, that's the thing looking at here where it's not one specific piece of that puzzle. So again, the January retreats, that you started to raise, things that have been looked at in the past. We thought they warranted consideration and were good ideas. If they didn't make it through, didn't get funded, we're going to bring those up again and see if it still makes sense and include those in the mix. And then we have the discussion around those leading to, we do a tremendous amount of research. My teams do a tremendous amount of research and evaluation of those ideas in that kind of February, March, April, May timeframe, and then we're prepping to prepare the same kind of decision packages with the help of finance in the July to September timeframe for submission for development or inclusion in the operating budget in that end of year, October to December kind of timeframe. January, February, we typically hear back what's been funded and approved, and that we have the ability to implement. Coming back with the board, discussing things that decisions that need to be made around it. If there's a board vote, we'll be doing that as are right now in this kind of June, July timeframe. That's pretty typical. And then trying to get it ready for communications in the open enrollment periods in October, November, and implementation on the first of the year following. But again, these are things that we're typically modifying something that already exists. We've got that additional 12 months into the future to actually get it to implementation. And I'm going to run through a couple of actual examples of ideas we've had, timelines to get implementation and approval, and kind of pause. We get to jump into the examples.
Yeah, John, Harry Watts, I had a question, but I think you already answered it. So if we had a benefit component that the PEB or the board enrollees brought forth that we wanted to do an adjustment to, there's an ability to, within the same budgetary guidance or the budget, to be able to make some modifications so long as there's it balances out in the end. I mean, give up something to get something. I think we did that a few years ago. We talked about it maybe with long-term disability or one of the disability programs where we could offset something new by touching something that already exists. I don't think I'm communicating that very well, but I think Dave understands what I'm saying.
Yeah, Harry, in the operating budget in the PEB section, which is usually right around section 212 of the budgets, it always shifts a little bit, but it's right around 210, 212. There is some language in the budget bill that describes that any savings from claims has to go into the fund, the claims fund, and that the board doesn't have authority to just spend that money. But there is also language that says you can make kind of a net neutral conversation. And that example, a great example of that was when this board worked on CAM therapies, chiropractic, acupuncture, and massage, and we brought you a bundle of things that were like, well, it actually would have cost more if you did just the acupuncture part, but by bundling all of these changes, it ended up being net neutral, and you kind of have the authority with budget neutral types of swaps is what I call them. And that is all language, that is all concepts that are supported and described within the budget bill itself as related to the board's essentially
Right,
spending
so I guess
authority.
the point I'm trying to get at is it doesn't always have to be a 2-year cycle. There are some ways to work within the budget to make some changes, but they're limited to net neutral.
Correct.
So I'm just going through a hypothetical because this comes up a lot. If members say, well, can't we get a bigger subsidy? That is something we would, obviously that's in law. And when we do a resolution, we're just executing the law, for lack of a better, implementing the law, for lack of a better description in this meeting. But let's say members are advocating from RPEC, for example, for a bigger explicit subsidy. Then we would propose that, but that would have to go through the legislative process. And then if it's approved, and then it's budgeted, then we could bring a new resolution next year for an increased, I'm just throwing this out because that's what I'm hearing, an increased explicit subsidy.
Correct. That has to go through the legislative process.
Right.
The agency and the board, neither of us has the authority to increase the budget expenses. There's a cap that's set in the budget, and then the board can choose to offer a lower subsidy. We've never seen that before, and it seems unlikely, and so we always bring the recommendation to approve the subsidy at the cap that's in the operating budget. But neither the board nor the agency can spend money that isn't appropriated or accounted for in the operating budget. So the exact dollars, so the cap that's on the explicit subsidy right now, $183 or 50%, whichever is less, that's language in the budget. And so that's the maximum spending authority, is the $183 or 50%. Adjustments to either that percentage or the dollar amount, that requires legislative action.
And I would just call out too that there's, with the idea of net neutral changes, we're talking about public funds and state budget. So there's an expectation, and we take it very seriously, that all of these things have a certain degree of rigor and discipline that is defined, in some cases legislated around them. And that type of net neutral change is one where the scrutiny that happens from finance about making sure that the assumptions, where the puts and the takes will happen, and are they truly offsetting? Do we have a reasonable expectation that they'll be offsetting? Are reasonable assumptions, right? So we have to apply that rigor to the analysis and be able to defend that. But assuming that it can, to your earlier question, then there are some other avenues that we can pursue to make changes, as Dave was describing and as you raised in the questions. Great question. Other questions? Okay, then as I said, I'd like to kind of walk us through three hopefully fairly quick examples, but let's take the time to discuss them, make sure everyone has a good understanding. But I think they really demonstrate the different processes that can be required and needed to get some of these ideas implemented, and why some can be shorter implementation timeframes than others, as we're starting to discuss here. So if we advance to the next slide, please. One we were just talking about earlier today and voting on, the at-home COVID-19 test. We were aware that both the federal and the state health emergencies would be ending for COVID in 2023. So back in March, we were looking at different options that might be available with the impending end of the emergencies. When the health emergencies actually ended last month, we started talking with the board about the idea of extending these, that we were going to have a gap between when the health emergencies ended and when we would actually vote and be able to start these up with the changes in the coverage. But we knew that there would be significant changes in the coverage allowed for these. In some cases, they had been covered as preventative measures during the pandemic. That was going to be ending, particularly for the over-the-counter tests, and co-shares would be applied to even the ones that were done in the provider's office or at their prescriptive inference. So we brought those up as what the cost implications would be. The board vote happened earlier today. And it was nice to see folks supportive of that, and will be again implementation for next month. So this one was very expedited because it was already, or expedited because it was already a benefit that had been existing. We were making modifications to maybe how many tests based on the funding that would be available, but the funding was already approved and in place. And so it was a much simpler discussion and a simpler funding process to get this one to implementation and approved. So this one was fairly quick when you think about it, right? And I wish more could be like that, but it's a very unique set of circumstances that led to this, where we already had the benefit in place. We're making minor modifications to continue to support it, and the funding had already been put in place to support it. And so we had that little bit of a gap between ending from the health emergencies and starting this up in July, but it will continue to be covered. So questions?
John, just to underscore the rarity of this, in the 10 years I've been with the PEB program and the entirety of the sub program, this is the only timeline that has ever been this aggressive and been able to be pulled off. And again, it's another unique aspect. As John said, it was a benefit that the light switch was turned off, and so we were simply turning the light switch back on. That's very different than creating something wholesale new. The uniqueness of the board taking a vote today and a benefit being live for less than 48 hours later I just need to manage expectations on that. This is extraordinarily unique.
Okay, if we go to the next slide. So this is looking at the changes that we're considering with vision hardware. We received some member experience inputs back in January of last year. So we started looking at what sorts of options might be available to expand the coverage and the benefit for coverage of vision hardware. We began assessments about how there were multiple components to this, but the piece that I want to focus on here is in PEB and SEB programs, we had two very different approaches to how vision was covered. In one case, it was covered and embedded in the plan, and the other, it was a separate entity. It was carved out and covered separately. So we had more latitude about the types of vendors and solutions we might be able to apply. Both approaches had very different pros and cons. And so we had to assess which one gave the most cost-effective outcome and gave members the best possible choices and options. And there was no, in my opinion, editorial flashing. There's no obvious, it would always be the answer is that, embedded or separate. So we really had to assess that and figure out what would be the best solution for the most members. We then came with recommendations about to the board and within the authorizing environment about what we thought made sense, and asked for funds. We developed the funding ask for that, and ultimately that would require an implementation, right? Because we already had both plans, both programs working in one in public employees, one in the school employees plans, but to make both the same would require a transition of one of the programs. Once that was funded and approved, we could then move on, and you see that in that July to December, that surprise, it ties to the decision packages and development of the operating budget. Then we could move to implementation. Once we had that approval and we were moving forward, we started planning for implementation in April, and there was a lot of work with the vendors that would be involved in that to be able to make that happen. And so that negotiation and that implementation planning really kicked off in April of this year, and then it will be for a launch effective in January of 2025, and that will align the two plans, multiple benefits from an administration standpoint with that. But also, we believe there will be a really positive outcome for members who will have differentiated member experience as a result. So a little bit more complex. It wasn't that, they weren't entirely new plans. We had both of them up and running. We had experience with both approaches, but it still required that funding approval process and some pretty extensive implementation planning to make the transition happen. So it was a more extended, not intentionally showing a curving path, but just to fit it on the screen, it was a little more complicated, but by far not the most complex thing we've ever chosen to do, because again, we had both in place. We had experience managing both. So again, pause for a moment. I know I tend to speak quickly. My kids and everyone else around me.
John, thank you. I have a question. It's my understanding that we do not have a vision plan for members, PEB members who don't participate in healthcare plan. If we don't have a separate standalone. If we wanted to eventually look at having a standalone vision plan, would that go through the same process?
Yep, exactly. And we'd have to work that through as a proposal and seek the various inputs and the funding to affect that, yes. And analyze the financial impacts as was done with this particular one. Yep.
All right, thank you.
John, I just want to clarify, that's actually exactly what just happened and we're working to implement in 2025. The the legislature, this is the change, and we'll be talking more about this next board season now that there will be issues to put in place. Right now, vision requires being in a medical plan. That's what you just said, John Comiford. As of 2025, it will be standalone and not embedded in the medical plans in the PEB program. We are between the last two bullets, implementation. The operating budget that was just passed by the legislature authorized carving out vision from the PEB medical plans to be standalone to align that structure with what the SEB program has today. I do want to highlight, though, that that is for our employee plans, not our Medicare plans, because we know that there are many that is around the employee-sponsored plans. And will likely, that collaterally will impact the non-Medicare retirees because they are pulled together in the same plans. But Medicare retirees, vision would stay embedded within the Uniform Medical Plan. For employees, we're on a path of implementing. That idea is what was analyzed in the timeline that John just went through and was authorized in the most recent budget and has an implementation date of January 2025.
I didn't recognize it because it said hardware, and I was thinking.
Yes. Mm-hmm.
Yep.
And now I just generated more questions, John.
Yep.
Well, it's just a comment. For me, I was scratching my head and saying, am I going senile? I don't remember having had a discussion on the retiree vision plan last year. So I went through all my notes. Well, that's beside the point, but I would have appreciated the distinction just so I knew I didn't know.
Yeah, and Elliot, I suspect it was a kernel of information buried in a lot of different pieces, especially last sports season. We had a multi-month conversation about dental, and we had a single meeting where we talked about vision. Very likely that could easily get lost, but that's why I wanted to say here, this change that was approved is not in the Medicare portfolio, it's in the non-Medicare portfolio with employees and non-Medicare retirees. Tom?
Well, that clears up a lot of things, because I remember last spring, we had quite an extensive discussion about dental and the idea of an incentive plan, and I didn't remember the same thing Elliot was talking about. I didn't remember much about vision hardware. If I'm understanding this correctly, what we have right now is for PEB active members, we have an embedded vision plan, and for SEB members, they have a separate. And what we're going to end up with is PEB and SEB having separate vision plans. Now, my other only
Except
other
for
question,
Medicare retirees and PEB.
I got that. So when they have these separate plans, is that something like uniform dental where you will have to pay separately also?
Separate premium.
In the context of employees, vision is collectively bargained to be fully employer paid. On the non-Medicare question, that's one of the pieces that we'll be bringing to the board to work out, but it would presumably be, we'll have to bring you enrollment eligibility policies related to that standalone benefit for the non-Medicare retirees.
Okay, thank you.
But on the employee side, it's collectively bargained to be the premium fully paid.
Okay.
Which is the way it is in SEB. Both programs for employees, it's a 100% paid premium by the employer.
Right.
Monica?
Pardon my ignorance here, but I have been a Kaiser Permanente member for the last 30 years, and vision is included in our medical plan. Can you clarify for individuals where those are already currently bundled, is there any impact of this discussion?
Yes, there is an impact, Monica. So for example, in the SEB program, vision is not embedded within the Kaiser Permanente plans. And so this will be a total removal of vision to standalone across the entire portfolio in the non-Medicare space for PEB. And I appreciate all these questions. The implementation timeline is January 2025. We purposely have not staged the conversation about vision since the legislature adjourned in April, because we will be bringing a lot more. But I appreciate knowing these types of questions that we're going to be bringing back, and just assure you that there is a plan to talk through vision and the implementation process next board season in anticipation of the 25 launch date. But it will impact everyone, Monica. John, I think you get to go to Exhibit 3.
Yep, and just really quick, Elliot, that was a good call out about the difference between Medicare retiree coverage and the commercial coverage, the current employees. sorry that I missed that. That was a really good call out. So thank you for the feedback. And then, yeah, on the third, the wellness platform. So this is one we've talked about a number of different times. This is something that's managed by one of my teams. So I live this on a daily basis. We had a program review that started back in April of 2021. We've had a long-standing relationship with a vendor that provides or manages our wellness platform. And we were looking at that experience, how they'd been performing and what they offered, and what else might be out there in the market. And that led to development of a decision package, considering that we may be looking at a full-blown procurement, going back out to procurement to see from a price perspective, from a benefit perspective, from a member experience perspective, was there some other alternative that might be a better fit for our members. That decision package was done in July. We got the final responses to that in the budget that was developed in December and January of 2021 and 2022. So in February, we wanted to identify what options really were likely to be included if we went to procurement. And so we initially sent out a request for information, an RFI, so that we could gauge what types of things were available and what types of questions should we be asking potential vendors to respond to when we went for the request for proposals, the RFP subsequently. Got a lot of really good information. We also got an in that RFI set of RFI responses. We also got a pretty good indication of who was likely, which vendors were likely to respond to the RFP when we subsequently put that out. So in July of last year, 2022, we actually launched the procurement for this and invited, as I mentioned earlier, there's a tremendous amount of rigor around a procurement and making sure that we're being fair in how we word the questions and how vendors are able to respond and interact in that procurement process with us as a state agency. And so we released the request for proposal, and that started that procurement process that we've been marching along. We got a number of different responses from a number of different respondents. We've been interacting with them to answer their questions and to get what we needed to be able to assess which one was likely to be the most effective, the best received by members, which one would have the most efficient implementation plan if we were to transition or to stay with our current vendor. You know, that was all another piece of the puzzle there that we needed to look at. And so there was a tremendous amount of work that went into interviewing those RFP respondents, getting the RFP back, scoring it, and evaluating their responses. I can't stress enough, having been in almost every one of those meetings and parts of that procurement, that's a tremendous amount of work to make sure that we're making the best selection for our offerings. And so that was going on over the course of 2022. We ultimately chose a vendor, an apparently successful bidder, and that started a contracting process. We had to negotiate a new contract. Even if we had stayed with the same vendor, we have to renegotiate the contract moving into the future. And so those contract negotiations, there's a fair amount of back and forth, as with any contract that you might negotiate, and getting to something that's workable and livable for us, for members, as well as for the vendor that we're going to be working with and that will be interacting with our members. That leads to a couple of other processes. One is around data security. As you can imagine, there's a tremendous amount of rigor and discipline about how we protect member data. And given that this is going to be members interacting about their health and well-being, there are different degrees of sensitivity to what types of data they might be sharing with that platform. And so we need to take that really seriously. And the state has different sets of protocols that help guide that. And we had to make sure that the vendor would be able to meet those requirements. And so that started. We have a data security review when we see their data designs that we have to make sure they meet all of the criteria that we have and that they're going to be able to implement in a timely fashion. And then we start the implementation process. That there was a little bit of overlap with that data security design review. And when we started the implementation, as you can imagine, just to be able to hit a 1/1/2024 implementation date. So multiple things had to happen here. That request for information leading to a full-fledged procurement, all the rigor that is created around a procurement, the contract development and negotiation, the data security and data design reviews, and then implementation planning. And we're in the thick of that right now for a 1/1/2024 launch. But all that started with an awareness that we've got a contract that's coming up for renewal. Do we need to take it back out for procurement? Sometimes the answer is yes, sometimes the answer is no, but this gives you an example of one that had virtually every potential component of this process involved and how it's stretched out really from an awareness in April of 2021 to now implementation in January of 2024. And it's no small feat, that data protection in particular. We've got to make sure that with something this has this sensitive of a set of information that it's secure as can be. Nothing's perfect, right? But we have those protocols for a reason, and we need to make sure the vendor can live up to them. So, questions about that one? And again, didn't mean to make it particularly snaking through, but it was a very involved process. And I can see Kurt has a question. I don't know if others do, but.
Yeah, and apologies if this is an obvious question, but you didn't say it and the slide didn't say it, but is this the Smart Health program we're talking about?
Yeah, it's actually the vendor that provides the platform that basically promotes Smart Health. When you interact with Smart Health, it's their platform underneath. And we had a vendor previously who provided that. We're going through changing that vendor effective January of next year. So the look will be in some ways similar. You'll hear more about it here on the board in the next month or so. Hopefully, if not, we'll be talking about it likely at the retreat. But the program will still be branded as Smart Health. We just have a different vendor. It'll be WebMD who will be managing the platform that delivers it.
Perfect. Okay, thank you for that.
Yeah, great.
Any other questions for John? I just want to make sure, do a time check. It's a little after 11:10. We are scheduled for public comment at 11:30 for 40 minutes. And basically, as we bleed into that, it'll reduce the opportunity for the public. So just be cognizant of that. Molly Christie, fiscal analyst in the, I'm sorry. Thank you, John. Sorry. I was getting a little, it's like, get out of here, John. No, sorry about that. I was feeling the pressure of time. Molly, a fiscal analyst in the Financial Services Division, is here to present the 2024 Medicare premiums, related financial information, and introduce the related resolutions. No action scheduled for this meeting on the resolutions being introduced today. Molly's materials are behind tab number 9. Molly, welcome.
Thank you, Chair McDermott and members of the board. Just for the record, I am Molly Christie. I'm on the PEBB finance team. And today I will be presenting a preview of the 2024 Medicare rates. These are the proposed rates. I'll include some detail on the UMP rate build specifically, something we haven't brought to the board before, as well as benefit changes for 2024. And then I'll introduce the proposed premium resolutions for action by the board at the July 12th meeting. Before I get to the premiums, which I know is what everyone wants to look at, I do want to provide some follow-up on a question that we received at the last board meeting. During the presentation of the Medicare 50 state analysis, Dave and I briefly discussed some different subsidies that are available for prescription drug coverage for retirees who are enrolled in Medicare. And then we received a follow-up question during the public comment on this topic. So I brought back some more detail from actually board meetings during last year's board season. So this material should look familiar. The slide describes the different types of funding available to or related to PEB Medicare retiree coverage. So the first category is federal funding that goes directly to Medicare Advantage and Part D prescription drug plans. We do call these subsidies, I have it in quotations there. They are subsidies, but they're really intended to reimburse for Medicare covered services and a portion of prescription drug costs. So this does effectively reduce the plan's overall costs and therefore the resulting monthly premium that retirees pay. And the payments are adjusted based on the reported risk of the population. They typically cover, or they do cover 100% of services covered by traditional Medicare, so that's Medicare Parts A and B, and then about 75% of pharmacy costs based on the standard Part D benefit. The other subsidy that we often refer to is the Washington State Medicare Explicit Subsidy. This is provided to retirees via a reduction to monthly premiums. The maximum value of the subsidy is set by the legislature in the state budget. For 2024, it is proposed to be $183 or 50% of the plan's premium, whichever is less. And the premiums presented today and approved by the board already have the maximum value of the subsidy applied. Finally, the state receives a relatively small subsidy for providing prescription drug coverage through UMP and the Kaiser plans that is at least as rich as the standard Part D benefit. The total value of the subsidy, this is the RDS or retiree drug subsidy, has historically been around $22 to $26 million, but it varies based on enrollment and drug spend. And it's deposited into the state general fund. This slide was also included in the last, I believe, 2 years of board materials, and it compares the total costs for UMP versus an MAPD plan, so a Medicare Advantage plus Part D prescription drug plan, and it's broken down by what CMS pays versus what the plan pays. And what this really illustrates, it's complex, so I will walk through it, but it illustrates the impact of that federal reimbursement that I just discussed, and particularly for Part D prescription drug coverage on the resulting retiree premiums. I'll note the numbers are illustrative. I did not update them from what you've seen last year, so they're not actual plan costs. They don't reflect actual premiums for 2024. UMP is on the right, and our MAPD, our illustrative MAPD is on the left. So if we look at the medical costs first, for both plan types, CMS pays for services that are covered by traditional Medicare, as I mentioned. In UMP, Medicare pays the claims first, and then UMP pays any remaining amount. That's the coordination of benefits that we've talked a lot about. For MAPD plans, Medicare pays a per enrollee prospective amount, and then the plan is the only payer on claims. So the plan takes that risk. For the pharmacy piece, Part D plans are significantly advantaged over creditable drug coverage because there are several different sources of federal funding. I won't go into detail on all of these, but these are direct subsidies, federal reinsurance, manufacturer drug discount program that cover a large portion of costs, and that helps keep overall premiums low. So you can see the value of this funding on the chart. It shows that the Part D revenue pays for more than 50% of prescription drug spending for the MAPD. So you see Part D revenue, and that's a negative $150 value of the total pharmacy cost. And UMP, however, is the only payer on pharmacy, so the plan pays 100% of the pharmacy costs. That is not considering member cost sharing. Yes?
Can we go back to page 4, where you mentioned the federal retiree drug subsidy?
Yeah.
That is not treated as an offset?
It goes to the general fund, and it's a little complex, but the state receives the RDS as revenue to the general fund. The Medicare explicit subsidy is also a state expense. So I have a slide that compares what the state spends on the subsidy and then what it receives in the general fund for the RDS, but it goes to that.
So effectively, it's factored in, just it's an offset of the state's contribution?
Yeah.
Okay, thanks.
So let's see here. So if we take these offsets that CMS, the subsidies that CMS pays for an MAPD plan compared to a coordination of benefits plan, that really does affect the bottom line, which is what a retiree pays per month as their premium. So the medical and pharmacy costs, when you add those up, equal the total bid rates. For UMP, the total bid rate is more than twice the maximum value of the explicit subsidy of $183 when I presented this last year. the subsidy was also at that $183 cap. So the remainder of the bid rate represents what the member pays in premium. For the MAPD, the medical and pharmacy subsidies offset those total costs. So that results in a significantly lower bid rate. We see the total bid rate for UMP in this example is $650, whereas the total bid rate for the MAPD is $200. So that MAPD plan has not reached the subsidy cap. Members receive then 50% of the bid rate, or $100 in subsidy, and pay a $100 premium. The takeaway for this slide is that despite paying secondary to Medicare with UMP, total plan costs and member premiums are higher than the MAPD because the plan does not benefit from different sources of federal funding. And on the next slide, this kind of speaks to your question, John. So as I mentioned, the state receives this small federal subsidy called the Retiree Drug Subsidy, or RDS, for providing creditable drug coverage in UMP, and then the two Kaiser plans, Kaiser Washington and Kaiser Northwest, for Medicare. And it shows the amount that the state receives in RDS revenue each year. That's in blue on the bottom, and then what the state spends on the Medicare explicit subsidy in orange. So while the state receives the RDS revenue as, into the general fund, it does have a significantly higher state expense on the Medicare explicit subsidy.
And very quickly, I just want to tie together that there is a certain amount of expenditure the state has to pay in order to receive the funds. So it's these two, this expenditure and this receipt of the RDS, do have a direct relationship.
Yeah, there is an actuarial valuation where our actuaries at Milliman look at the drug benefit in UMP and the Kaiser plans, and they have to assess whether that drug benefit and the cost of that benefit to retirees makes it equivalent in coverage to a Part D, a standard Part D plan.
I think we can go through this for a couple of years, then you start to get used to it and understand. But that was great, thank you.
Yeah, of course. So next I'll share a brief summary of the 2023 PEB Medicare enrollment by plan. Between 22 and 23, there was a significant shift in enrollment. I think we have discussed this already this board season, but I will just offer this as a reminder. UMP membership decreased about 17%. It still has, though, the highest enrollment of all plans in the Medicare portfolio at about 41%. Both of the United Healthcare plans had significant increases in enrollment, particularly the Complete plan, which more than doubled. Premera Plan G also increased by about 10%. So we have two Medicare supplement plans, Plan F, which is closed to new enrollment, so that is only grandfathered members, and then Plan G, which is open for new enrollment. So Plan G is where we saw that growth. And then the Kaiser plans had a small decrease in enrollment, but I would not really consider it significant. I would say that the Kaiser plans generally remained relatively stable. All right, in the next section, I will share the proposed Medicare premiums for 2024. So this table shows the 2024 proposed single subscriber Medicare retiree premiums after application of the explicit subsidy, as well as the percentage and dollar change compared to the 2023 premiums. These premiums also include some benefit changes that I will walk through later in the presentation. So right off the bat, you see that premiums are increasing across all plans. The greatest increase is for UMP Classic, and that's coming in at $95 per month, or 22% over last year's premium. This includes the hearing aid benefit resolution that was approved by the board in the last meeting, and that resulted in a $6 reduction to the 2024 rate for UMP Classic. And I will walk through the specific drivers of the UMP rate shortly. The Kaiser plans are increasing by about 8 to 10%, or $14 to $18 per month. Kaiser Northwest is also now at the $183 subsidy cap. United Healthcare is similarly increasing by about $13 to $15. This represents about a 10% increase over last year's premiums. As a little bit of context, the fully insured plans have shared that inflation has been a large driver of increased rates. There are also a few other factors at play. One of these is that the federal government made changes to risk adjustment methodology for Medicare Advantage plans that was effective this year. As a reminder, CMS adjusts the amount that MA plans are paid in reimbursement for covering traditional Medicare, and that's based on the reported risk of the covered population. So these changes are resulting in less revenue, generally speaking, for Medicare Advantage plans, and in some cases, this is resulting in increased premiums. For the MAPD plans specifically, because they have that Part D prescription drug coverage, there were also federal changes made by the Inflation Reduction Act that actually lower member out-of-pocket costs under the standard Part D benefit, but that does result in increased costs to the plan. Moving on to the next slide. This shows the same monthly single subscriber premiums as well as, I think we're one back.
This one's between.
Oh, okay. Sorry. Flipped around in mine. So we also brought back this slide. This shows the annual single subscriber premium, or the monthly single subscriber premium multiplied by 12. We shared this last year and received feedback that it was helpful, so we have brought it back. All right, so now on the next slide, okay, so this shows the same monthly single subscriber premiums, and then it also has the monthly subscriber and Medicare eligible spouse or state registered domestic partner premium. So this is talking about 2 Medicare eligible members, and the monthly premium is 2 times the single subscriber premium.
Can I ask one more question?
Yeah, of course.
The Plan F and the Plan G, are they exactly similar to what the public can get in the market, or do they have additional bells and whistles?
They're not customized for PEB, so they are the same plans that are
So
available.
there's no bells and whistles, okay?
Correct. All right, on the next slide. So this slide shows the value of the Medicare explicit subsidy by plan. This is calculated based on the plan's bid rate. As you've seen in the footnote on all of these slides, the proposed subsidy is $183 or 50% of the bid rate, whichever is less. I want to provide a reminder of all of this terminology. I know I'm using a lot of different terminology. So the bid rate is the total monthly premium. We use premium a lot, premium and bid rate. But you can think of this as like the total price to enroll in a plan on a per member monthly basis before we apply the Medicare explicit subsidy. So typically when we refer to premium, that's the amount that retirees pay each month. So that's what comes out of retiree pockets to pay for enrollment or to pay for coverage in one of the PEB plans. So the retiree premium is the total bid rate minus the subsidy, and then there is the addition of an administrative fee. So that's where we have composite rate come in as well. This is the bid rate plus the HCA administrative fee. So a lot of different ways to kind of talk about some of the same things. You can see on this table now that there are 3 plans, as I mentioned, that are at the $183 subsidy cap. These are UMP Kaiser Northwest Senior Advantage, and then the Premera Supplement Plan F for members who are enrolled in Medicare due to a disability. The UMP plan and the Premera Plan F have been at the subsidy cap. The Kaiser Northwest plan is at the subsidy cap for the first time this year. All right, moving on to the next slide. So to better illustrate the relationship between the Medicare subsidy and retiree premiums, I've also brought back this slide from last year's presentation. This compares UMP and Kaiser Washington bid rates, their subsidy, and then their premium from 2018 to 2024. So you see the total bid rate is the total cost of the plan, and then you have a portion of that representing the Medicare explicit subsidy, and then the remainder is the premium. And Kaiser Washington is on the left and UMP is on the right. We just chose Kaiser Washington as an illustration because they have not reached the subsidy cap yet. So this illustrates the effect of that on the resulting premiums. And the takeaway is that the total cost of the plan or the bid rate is a function, it impacts the value of the subsidy and the resulting cost to retirees as their monthly premium. So for plans like Kaiser Washington, they've historically had lower bid rates, resulting in a 50% reduction to the bid rate via the explicit subsidy. That also means that any increase to the rate from the prior year only results in a 50% increase to premiums. For instance, if you have a $10 rate increase, that's a $5 increase to premiums because 50% of that is being cushioned by the value of the subsidy. But that's only for plans that have not realized the subsidy cap. So in contrast, UMP has comparatively high bid rates. We've leveraged the full subsidy amount since before 2016, which means that as plan costs have risen, so have retiree premiums, because they're absorbing the full value of those increases to bid rate as increases to premium. I'm going to take a sip of water for a moment. Okay. Next, I'll move into detail on the development of the UMP Classic Medicare bid rate. And these first few slides are a little bit of context again before I look at those specific bid rate drivers. So this is a reminder that UMP Classic Medicare is a self-insured plan. It coordinates coverage with traditional Medicare, and it's administered by Regents. Regents is the third-party administrator. As a self-insured plan, HCA sets UMP rates in consultation with our contracted actuaries at Milliman, and the goal of this process is to set rates and resulting premiums based on the required cost to pay claims and to administer the plan. Additionally, as a self-insured plan, HCA only retains enough to cover actual costs to administer the plan, including statutorily mandated reserves. There is no profit margin built into UMP Classic rates. This means that changes in yearly rates are reflective of actual changes in healthcare costs, utilization, and benefits.
I'm trying to interject as little as possible. Molly does an excellent job. I want to drive home one point here, though. Many times people will ask me or make the assumption that Regents is part of the UMP rate setting process. And Molly has just said, I think twice, that's not the case. I want to reinforce that by, I got a call Tuesday morning from our Regents account manager who had just seen the rates that were published, that they saw them at the same time the public was published. But they were published and the public saw them. Regents absolutely does not have a role in this process. They didn't even see these rates until the same time the public did. I just thought that was a great illustrative example to drive home that point. Keep going, Molly, you're doing a great job.
So on the next slide, I've also, a lot of this I'm bringing back, not for the first time, but again, it does take a few years to kind of piece it all together. So the UMP Classic Medicare rate is primarily driven by pharmacy costs. This has not changed. UMP is the only payer on pharmacy, meaning that the plan does not receive reimbursement from Medicare. Specialty drugs in particular continue to drive cost and future trend. I also shared in my last presentation on the 50-state analysis that UMP covers supplemental benefits such as vision and hearing coverage that are not typically offered by coordination of benefits plans in other states. In addition, most retirees in the plan pay $0 out of pocket for medical benefits. So it is very comprehensive or extensive medical coverage. Next
Molly,
slide.
is the formulary for the UMP Classic Medicare drug formulary the same as it is for UMP Classic?
Yes.
Employees?
Yeah.
Okay.
So Medicare retirees in UMP and non-Medicare members have the same formulary and the same
All right,
benefits.
thank you.
Yep. Washington is one of only 6 states that offer a self-insured Medicare coordination of benefits plan, which on average, as I showed at the last meeting, have higher premiums because they don't receive the same funding provided to MAPD plans, so Medicare Advantage and prescription drug plans. As a result, UMP Medicare premiums are expected to continue to increase in future years based on what we're seeing in enrollment and cost trends. So on this slide, I'll walk through more detail on the components driving that $95 monthly premium increase for UMP Medicare. The way that we build the rate is that we start with claims costs during an historical base period to set what we're looking at for the future. So for 2024 rates, we're using actual 2022 claims experience, and then we have to trend it forward 2 years. The first section, labeled projected to actual 2022 base claims experience, and PMPM means per member per month, shows that the plan had favorable medical and pharmacy base period experience compared to what we projected when we set rates last year. So it's favorable based on what we thought would happen. And for medical, this is probably largely driven by lower hearing aid utilization. That was a large piece. It lowered in 2022. And then for pharmacy, we also had an increase in drug rebates to the plan when we switched to a new pharmacy benefit manager that offset some costs, and that was kind of a 1 year within year thing. In total, this resulted in a negative $6 claim impact. Then we had a positive increase of $3 for reserves and administrative costs, resulting in a total claims experience impact of negative $3. We then take the updated base period experience, which is the total claim cost for 2022, not the negative $3, but the total cost. And then we apply 2 years of medical and pharmacy trend. So despite this favorable experience, you see this negative $3, we still have costs that are subject to high trend, particularly for pharmacy. And as you see here, the combined medical and pharmacy trend for 22 to 23 and then 23 to 24 accounts for $57 of the rate increase. I want to speak to that section a little bit more. That you see that there's this incremental rate increase attributed to 22 to 23, that's $5, and then you look at 23 to 24 and go, gosh, well, that's 52. Something must have happened in 2022 to 2023 that was different. And what this actually shows is a comparison between trend in that we used to set rates for last year. So there was $45 for 22 to 23 that was already included in the 2023 rates. So a big piece of that year's trend was already included in the current year's rates. This $5 represents an adjustment to that trend assumption for the 2024 rates based on more recent claims experience. So in other words, the amount of the total rate that was attributed or that is attributed to 2022 to 2023 trend is really about $50, so not that far off from 52. But we underprojected when we set 2023 rates by about $5. So we have to make up for that $5 in the next year's rates. And that's captured as an incremental increase. There was also a large enrollment shift in 2023. I've already mentioned this. We had about 10,000 members leave UMP. I'll talk about this a little bit more in the next slide, but many of the healthier members left UMP, resulting in a relatively greater per member per month cost for the remaining population. And that's reflected in the $47 enrollment shift impact for 22 to 23, and then again for 23 to 2024. So that leads us to a total impact per member per month of $101. We take the negative $3, we add the $57 trend impact, the $47 enrollment shift impact to reach $101. And then there is a $6 deduction due to the hearing aid benefit limit that was approved in the last meeting for a total final increase of $95 per member per month to premiums. This slide provides additional detail on the enrollment shift impact of $47. So as I mentioned, we had a large afflux of members from UMP in 2023. We predicted that this might have an impact on the cost of the population that stayed with UMP. And to confirm this theory, we had Milliman use a clinical risk grouping tool to determine the health of the members who stayed with UMP and what their relative costs were. And at a very high level, we found from this analysis that a greater relative proportion of less healthy members were retained in UMP, which results in increased cost. And this analysis was at the member level. So we were looking at individual member costs and utilization. The next few slides will cover benefit changes that are included in rates for the fully insured plans specifically. So all of the fully insured plans, exclusive of the Medicare supplement plans, will align with the UMP benefit renewal period of 36 months for coverage of hearing aids. Currently, the plans cover hearing instruments every 60 months, so this is a benefit enhancement. However, the existing benefit limit, so that's the plan's allowed amount, will not change. In this case, for Kaiser Northwest, the current benefit is $1,400 per ear every 60 months, and this will change to $1,400 per ear every 36 months. That is the only benefit change for Kaiser Northwest. Kaiser Washington has 3 benefit changes consistent with the other fully insured plans. You see the alignment with a 36-month hearing aid benefit renewal period. And then there is an increase in visit limits for chiropractic, acupuncture, and massage to 24 each per plan year. And this is aligned with the non-Medicare plans and also with UMP. On the next slide, Kaiser will also remove the first fill program from the original Medicare plan effective 2024. The original Medicare plan has about 3,300 members, and it's offered for retirees who do not live in the Kaiser Medicare Advantage service area. First fill did not apply to the Medicare Advantage plan, which has about 20,400 members. Consistent with the Kaiser plans, United Healthcare is also enhancing its plan's hearing aid benefit to align with UMP's benefit renewal period of every 36 months. So the current benefit is $2,500 combined for both ears every 60 months, and that will move to $2,500 combined every 36 months. And this is the only benefit change for United. And the next slides introduce the proposed PEB Medicare premium resolutions. As a reminder, when we ask the board to vote on the Medicare premium resolutions on July 12th, you will be asked to vote per carrier, which adopts all of the plans offered by that carrier and PEB, as well as the premiums and the benefit design changes underlying those premiums. So I will walk through each of these individually. This proposed premium resolution would set the Medicare explicit subsidy at the cap that was set and funded by the legislature for 2024, which is $183 or 50% of the premium, whichever is less. The board has the authority to set a lower subsidy amount, so this is the resolution where the board could take action on that. The next resolution adopts the Kaiser Northwest Medicare premium. The one after that adopts the Kaiser Washington Medicare premium. The following resolution adopts the United Healthcare Medicare premium, so for the two UHC plans. This resolution adopts the Premera Medicare supplement premium, so we have 4 premiums for the 2 Plan F and 2 Plan G. And then the final resolution adopts the UMP Classic Medicare premium. And that is the conclusion of my presentation. My email is available. Please email me if you have questions. Also would welcome questions now.
John?
Molly, on the negotiations with particularly Kaiser and United Healthcare, were they easy negotiations, or were they very difficult? Did you have a lot of back and forth? Did they try to raise rates? They did.
So the rates presented here are not in all cases the original rates that we received, or not in any case the original rates that we received. There is always a negotiation process while we expect our carriers to submit their best and final offer the first time. We always push. And as I mentioned, there were some federal changes that are putting pressure on Medicare Advantage plans, and it was our position that changes to our rates should reflect changes in costs for our population specifically. And so I wouldn't say the negotiations were. Everyone came to the table with opinions, and I think we reached a good resolution. So it wasn't difficult in the sense that we didn't work well together with our carriers, but we drive a hard bargain, I think.
I'm just hearing in the industry that there was a lot of issues that were raised by the carriers for the Medicare Advantage plans this year, relative to cost. I was just curious if we did a really good job, which it looks like we did, in negotiating.
And I just want to remind, for both the public and board members, executive session, we go along the journey, and there's reasons, the proprietary nature, that we don't share every stage of the negotiations publicly, but the board should be aware of some more details of the journey because of the executive sessions we've had over the past couple of months. But to your point, yes, these were, I'm not going to repeat Molly. Elliot, you have a question?
Yes. What would also help the public, sometimes I forget this, HCA has to work with what the federal government hands them. They're not a kingdom on a hill run by some king somewhere. And you wisely mentioned that there were some changes from the federal government that affected plan costs for these Medicare Advantage plans. Is it possible in the next month and at our next meeting, gosh, it won't be a month, it'll be in a couple of weeks, or to just summarize what some of those things have been? Because it would help put, frankly, HCA in better context. And what you have to deal with. You work within a federal framework as well as a state framework. So I would like to see what some of those things are, so I understand what all the moving pieces on the chessboard are. I'm only seeing the queen, but not the king.
Elliot, I'd love to just try to answer that question right now for you and everyone. Because there's a direct story arc that people can see. It's just connecting those dots together. Many people in the public and the board and the agency are well aware of the Office of the Inspector General report that talked about the increased or large payments that may or may not have been justified to go to Medicare Advantage plans. There were lots of media articles about it in the New York Times, the Washington Post, pick your favorite newspaper, a variety of wide-ranging newspapers. And CMS responded to that and changed their methodology. Molly referred to that, changed the risk adjustment methodology to address what were the criticisms about the over revenue expenditures in Medicare Advantage. That then is squeezing the profit balloon that is happening within the Medicare Advantage space. And so that's where Molly was saying, when we went into negotiations with the carriers and they were talking about the changes in the federal government, we're like, we're not going to let you just squeeze the balloon and just keep your profits and push it over onto the members. And so that's where the negotiation was about. Molly had just said, we were so focused on the changes for costs need to be attributable to our membership. That's our position, not you got the balloon squeezed over here by the federal government. But that is a narrative and a piece of the puzzle that's there. So there's a direct relationship between that story arc of Office of Inspector General report, news articles about Medicare Advantage expenditures, CMS changing its risk adjustment strategy for the next year, and then our negotiations. Is that helpful?
Well, I did read all of those, and I've read the Inspector General's report. But what I'm interested now is to see, and maybe later you can give me a site or send me a site, so that I see what changes CMS actually imposed on these Medicare Advantage plans. Ironically, the press, probably because people only like bad news, didn't cover what CMS did in response. I never heard of that.
Other questions? John, or do you have a question?
No, I'm sorry.
Okay. Mike.
Oh, yep,
There
sorry.
you go, bud.
I
All right.
like the color.
It is pretty. And the green ones up there, those are nice too. All right. Molly, thank you.
Thank you.
Yep, appreciate it.
Thank you, Molly.
All right, next up, Ellen Wolfhagen, Senior Account Manager in the PERB Division, is going to be providing us a Medicare update by reviewing some of the work done by the agency over the past year and next steps for future continued work. Materials behind tab number 10. Welcome.
Thank you. Good morning, Chair McDermott and members of the board. For the record, my name is Ellen Wolfhagen. Next slide. So earlier, John Parton described the overall timelines, and Molly just previewed the 2024 Medicare rates. I'm going to discuss some recent and next steps, but first I want to start with a reminder. UMP Classic Medicare is not closing. It will not close. It is open for enrollment. We can't say it often enough, so I'm going to start off by saying that. And my discussion is a review of past board presentations. So I want to lay the groundwork here of an understanding. What we provided over the course of the board season is an understanding of how Medicare works. So we started off with how Medicare operates. So Part A, which is inpatient services, Part B, outpatient services, Part C, which is Medicare Advantage, Part D, prescription drug costs. The plan interactions with Medicare. So we have a coordination of benefits plan, we have Medicare Advantage plans, we have Medicare Advantage plans that include prescription drug coverage, and we have Medicare Supplement or Medigap plans. We talked about retiree outreach and listening sessions updates. You are probably sick of them. I've done them monthly. We talked about the process for prior authorizations and Medicare appeals. We talked about CMS proposed rules on Medicare Advantage. So just a reminder, among the items in the proposed rules, prior authorization would be good for at least a year. The creating an equity between how Medicare Advantage plans and traditional Medicare work, and a crackdown on the mass advertising that Medicare Advantage plans do. Those are just some of the things. The Medicare rules were proposed in December. Comments were due in February, and I will talk more about that as we move on. Next slide. In contract administration, we talked about things like United Healthcare had a glitch in the file system that impacted some members' enrollment dates, which they corrected, and this is just ongoing contract administration updates. We talked about the income-related monthly adjustment amount, which affects Part B, like boy, premiums for Medicare, as well as Part D premiums, and this is something that's imposed by CMS. We talked about the CAP surveys, which are generally done on the national contract level, so not PEB specific. We talked a little bit about pharmacy appeals. We will do more in the next meeting, July 12th. And on the retiree communications update, there's an updated web page. We talked about some things there as well. Next slide. So some specific items that the agency has been working on related to Medicare offerings. We initiated in the spring of 2022 actually, a 50-state research analysis, which Molly reported on at the June 8th meeting. In the fall of 2022, we hired a project manager and began planning listening sessions for the spring of 23. In the spring of 23, we consulted with other states on specific benefit designs and financial structures and plan options. And Dave and I attended a public sector healthcare roundtable conference. Dave, would you like to talk about that?
Yeah, the Public Sector Healthcare Roundtable is a entity of a variety of people like me and our programs is what I would say, our programs, state employee and pension programs for state government. And it is based out of DC and is often one of the people that's in the rooms or consulted by our federal legislators working on issues related to healthcare and pension benefits for public sector employees. And we went to this conference in November. It's an annual conference. And actually, as a result of that, the Public Sector Healthcare Roundtable, which tends to have a little bit more advocacy role, is creating a research institute. It actually launches today. I'll send out the announcement because I'm one of the inaugural board members on that entity. And part of that new entity's goal is to work on nonpartisan, unbiased research related to public sector employee and retiree health and pension benefits. A particular focus on the health piece, but there is a lot of overlap with pension pieces. And one of the first priorities of that new research institution is additional research on prescription drug costs in retiree areas. What the Public Sector Roundtable had recognized was that there were a variety of potential gaps in research that exist, gaps in research that can help inform some of these policy topics. And so that's where this idea last fall began getting some steam. And so this new nonprofit organization is being spun out and created, again, launching literally today. And I'm very involved with it. It involves multiple states: Texas, Colorado, California, Ohio, and Kentucky are the other states that are part of the board. Real quick, I saw pens writing fast: Texas, Washington, Colorado, California, Ohio, and Kentucky. And we're the board that I'm now part of is helping craft the research topics that institute will be doing as we spin out. And so it's another example of my particular role on behalf of the agency stepping in and trying to find ways to support action at the federal level.
Is there a name for this illustrious group?
Public Sector Healthcare Research Institute, I believe, is our formal name, but I will send out the information on the press release that's being done today.
Thanks, Dave. And as Michelle just reported, we conducted a post-open enrollment communications survey. Next slide, please. So as I said, the proposed CMS rules were issued in December. Comments were available. We did make comments in February, and those were reported to the board as well. In March, Dave met with the CMS administrator, highlighting federal Medicare subsidy concerns. Dave, do you want to speak any more to that?
It was Dave and Sue. I just want to make sure that everyone knows that I think we've talked about that before in the presentations, but it was an important conversation that we were very fortunate to be able to meet with the CMS administrator and directly brought concerns and highlighted the impacts that our retiree portfolio is having. And that was, I think, a fortuitous timing. That was right in the middle of the CMS rulemaking, which gets back to Elliot's question earlier of understanding a little bit more about what CMS actually did with the risk adjustment process. But it was just, the way these things work is those opportunities present themselves, and it just kind of adds to the overall narrative that's happening within a federal agency or a leader of a federal agency to be able to promote change.
As Molly has reported, we performed financial analysis on specific benefit design ideas, and those were presented in April. And we hosted the 24 retiree listening sessions and 3 public forums. And we heard feedback to an earlier comment that came up about simplifying and condensing our information. There's a lot of information that we provide. People want it in a more digestible format. But we also heard that there's a preference for emails as much as possible, and the snail mail, the printed materials, for things that are really detailed so that people can go back and refer to them later. Next slide, please. We launched an online retiree resource page called Retiree Engagement, and I previewed for the board the frequently asked questions and the Medicare myths that are presented there. We contracted with an outside consultant firm on communications to improve print and web communications, and that work is ongoing. On June 8th, Molly presented the 50-state research results, and in mid-June, the congressional delegation letter was sent, and there's more on that on the next slide. So Director Sue Birch's letter was sent to the Washington congressional delegation, which is senators and representatives. It set out the financial disadvantage to members enrolled in UMP Classic Medicare. I pulled this quote from the letter because I think it's important. It is now the traditional non-privatized original Medicare plan designs, so read UMP, that are at such a competitive disadvantage that they need a similar financial support to survive. And a copy of the letter is included in the appendix, and the letter is actually seeking support. I see that that was left off the slide, unfortunately. So upcoming agency activities, what's currently underway is a complete review of the listening session summary notes. The listening sessions were held from February through the end of May, so all of those notes are being compiled. We are researching the ability and impacts and timeline for various options, like converting UMP Classic drug coverage to a Part D plan that might impact the premiums for UMP Classic. So again, we looked at the 50-state research. Suggestions came up during the listening sessions and from correspondence as well. And We had board comments and suggestions in June of this year. So at last month's meeting, the idea came up about using a Part D plan for UMP pharmacy. The legislative report on the listening sessions as well as potential changes to UMP is due December 1st, 2023. When it is complete, it will be posted to the HCA website, and we will be presenting it in January to the board at the retreat, and we'll go over it in detail. And we are preparing insights for the 2024 board season on the comparison between UMP drug coverage as it currently is and what it might be under a Part D plan. And that would include the impacts of things like the Inflation Reduction Act.
I just want to say before we move on that no decision has been made. You're seeing a lot of points about the agency is going to be looking into. We're doing that research phase. This is partly why John Parton's presentation was earlier today, to talk about the relationship of evaluation, then funding decision, and all this stuff. This is that researching stage. We've been in that mode for the last year in response to what's next, making sure that we had our retiree listening sessions, at least for that segmented project. Again, we're going to be finding a time of year to make sure that's a permanent work stream. I just want to reinforce, you're seeing several parts about Part D plan. I don't want people to assume a decision has been made. We are just in the research phase, but we want to make sure that we're also being responsive to the question of, well, what is the agency doing? And so that is what the that idea keeps coming up in multiple areas. So the viability and potential impacts of that is a significant focus of some of the work on what could be a future state. But no decision has been made.
And to build on what Dave just said, it's important for us to look at all the options. Not all options are viable, but there are, as John Parton pointed out, there's a long timeline that's involved in making those changes. And so because major changes often take multiple years, we need to be positioned so that we've done the research and we've looked at all the potential impacts before we get to a decision point. And finally, HCA will continue to keep a steady pace on this work. We are balancing the feedback that we hear, the ideas that come up, and what we can actually do to maintain as much flexibility as possible for an early implementation date, with a reminder that implementation is often 2 or 3 years down the line. And that's the end of my presentation. Just a reminder, the congressional letter is included in your appendix.
Any additional questions for Ellen? Tom?
Yes, Ellen, you said there was one thing that was left off the bottom of, I can't remember if it was page 7 or 8.
It's the, slide number 8,
Yeah.
and it says a copy of the letter seeking is included. It should say a copy of the letter seeking support is included.
Okay, so that good, because so what I'm interpreting that is, if I were to write a letter in support of that, that would be okay.
Absolutely. In fact, the more we have discussed with various retiree associations and others, that if there are letters in support of our letter that either direct legislators to our letter, or cite our letter or include our letter, that all gives more support to the original letter. And the original letter is included in your appendix.
Other questions or comments? Ellen, thank you.
Yep.
All right, we're in the public comment phase here. I see high attendance on Zoom that typically occurs for our board meetings. We have, well, we're going to say 12:10 right now, but we're going to take a look and see how many individuals.
Yeah, Chairman McDermott, I would recommend we see how many people want to speak, and we can try and balance a couple of different competing interests. I suspect we should dedicate more than what's on the agenda for 8 minutes for now, as we ran over on some of the important topics, but it's important to give some dedicated space to public comment. So I recommend we see how many people there are and kind of try to balance those interests.
Okay, fair enough. Let's, if the public could raise their Zoom hands so we can get a tally.
who are still raising their hands, so appreciate that. We'll just wait another moment just to try to get as comprehensive a list.
I have my hands up, and it's not showing.
Okay, thanks. You're right, Francis. Thanks for acknowledging that. We'll make sure that you're on the list. If anyone else is having trouble or any issues with raising their hand, you can also turn on your camera and wave your hand, and we'll try to capture that too. While we're making the list, I'll just make sure people are aware of who we've identified so far. We have Carol Dotledge, Aruna Buddha, Amy Fortier, Linnea Mulder, Nathan and Katie Johnson, Laurie Widener, Sharon. Sharon's iPad number 2. I'm sorry, we don't have your last name. Annette Barca, Francis, who just
take a little bit to get this.
who just raised her voice. And then Lisa. So we're at, Chairman, we're at around 10-ish people.
10-ish people. Anybody want to cut the limit 2 minutes?
Ask
2 minutes
people
per
for
person,
two
about
minutes.
20 minutes. Okay. All right. Why don't we start with Carol? We're gonna give everybody a couple of minutes per comment.
Thank you. I'm Carol Dotledge, and I'm the president of a retiree chapter in Pierce, Kitsap, and South King County. And I wanted to ask a couple of questions and make a few comments, if I may. I want to start with a question. My question is the COVID vaccine still covered by UMP?
Yeah, we're gonna take the questions and then we'll come back for answers. This is more on the comment side.
Okay. And then I would like to know about the difference in the standards between Part D and UMP. I'm very glad to hear you're going to do listening sessions in the future. I think that's really important. I wanted to share with you that an online survey does not work well for retirees. You had 2,000 respondents. We have 11,000 members. So that tells you something about what kind of response you got from the elder population. And my next comment is that I heard that people are sick of the listening sessions. I totally disagree. I think I'm very heartened to hear you're going to continue to do that, and I thank you for that. And I have one more comment. I thought you were going to take comments after each section, so I sort of tried to take notes and write down my questions and responses at the same time. It didn't work very well for me. So I would hope that you would change that format so that people can talk about the issues as you raise them. I think that would be a better communication opportunity. I also want to share with you that I'm very disheartened by the premium rates for UMP. UMP is very important to me and my husband. We want to keep it. I looked at the rates. I don't know how I can survive and pay those rates. And I had group health, or what is now Kaiser, before, a long time ago. I swore I would never go back. And my experience with UHC is negligible, but I did serve on a national board at one point in time, and the complaints about UHC nationally were huge. So I'm left figuring out what I'm going to do about my health care, because I really need UMP. I have confidence in it, and I don't want to change, and I don't know how I can possibly afford it. So thank you for listening to me today. I appreciate the information that you provided, and I appreciate the work that you've done. Thank you.
Thank you, Carol. Next up, is it Aruna? Aruna?
Hello. Yeah, good afternoon. Thank you for giving me a chance to give an input. I would like to urge at that research institute, Public Sector Healthcare Research Institute, since it's a nonpartisan, nonprofit research institute, to make every effort to strengthen original Medicare and decrease the, disparities between original Medicare and Medicare Advantage. That will be one important thing. Second point I have is about, National Institute of Health, and many of the national institutes National Cancer Institute provide funding. Those are taxpayer dollars that are going toward the research for developing new medications. And so having that information as to how much university-based funding is going, or NIH or national institutes-based funding is going toward the new drug development, and the big pharma's claims about that research funding would go down if the prices would research would go down if the prices would be decreased. I truly learn a lot from attending this meeting. I appreciate this part about how the process of drug approval from FDA to the payer making decisions is made. Thank you very much.
I appreciate your comments. Thank you. Amy?
Hi, Amy Fortier, retiree in SWIM, Chair McDermott, members of the board. Thank you for an extremely informative meeting. There's so much material, and 2 minutes will not be able to be enough, but there is the next meeting on the 12th. So I want to commend Dave and Sue for beginning the dialogue with the CMS. And I'm wondering, John Parton's presentation was very illuminating about the benefit cycle. And I'm wondering if there may be able to be a future presentation about the Medicare and CMS rulemaking cycle, so that we'd have some opportunity for input and offer advisory information when you're making input back to them. I also, again, want to commend you, Dave, for being part of the Public Sector Healthcare Institute, and look forward to the information forthcoming from that. That's definitely long overdue for many of the challenges that we're facing now. And a third, kudos for the additional communication information. Look forward to seeing the HCA news and the retiree resources. Thank you for taking the time and hearing some of the things that have been coming from both the listening sessions and individual comments.
Thank you, Amy. Is it
Linnea.
Linnea?
Whoops.
Are you with us, Linnea?
Yes, yep, sorry.
There you go.
There we go. My name is Linnea Mulder. I'm a retiree and retired nurse. Thanks to Chair McDermott and the member of the board. I still have some basic questions about PBMs. I had looked at the HCA site to see if I could identify who our PBM was for uniform. I didn't find anything, but I did then find an article. The Northwest Prescription Drug Consortium is pleased to retain MODA as their contracted program administrator and begin using Navitus as their pharmacy benefit manager, effective January 1st, 2022. So, but in Luke's presentation today, it sounded like MODA is the PBM. So I'd be interested in knowing who our PBM is. Navitus is owned by Costco and SSM. And then another question is, does Navitus or MODA negotiate and determine drug tiers with HCA? What strategies does HCA employ to better navigate their relationship with Navitus or MODA to provide access to medications at the best value? Does the P&T committee interact with PBM? And thank you very much for the comprehensive letter that was sent to our congressional delegates. And thanks for the opportunity to talk. Thanks.
Thank you so much. Nathan and Katie?
Hi, I'm Katie Johnson from Tick Clock Drug in Colfax, Washington. And I just wanted to again comment, I saw about Kaiser that there, is possibility of removing the first fill program. I just want to say again that we really support that.
we're still having patients come in struggling with mail order, getting it set up. And we live in a rural area, and it's just been really hard for our patients to have to try to go through the mail order for these fills. And even just yesterday, I still had somebody come in who's met their maintenance fills and is struggling to get it set up when they call in. It's an automated system, and it just continues to be a struggle. So I am hoping that it does go through, that they remove that first fill program. I think it's really important for the rural members.
Thank you, Katie. Next up is Lori.
Good afternoon, members of the PEB board. My name is Lori Widener, and I'm the Executive Director of the Retired Public Employees Council of Washington and the Chair of the PEB Stakeholders Medicare Coalition. Our PEC represents about 12,000 public sector retirees, and the coalition represents 9 not only senior but labor-related organizations. First, I'd like to start by thanking Dave and his team for working so closely with us over the last year to hold the stakeholder engagements that were required under Resolution 2022-16. HCA staff valued hearing from retirees about their healthcare plans and the need for service improvements by the agency. And retirees appreciated the opportunity to share their lived experience with the healthcare plans and the open enrollment process. I attended a number of the sessions. I've also read all of the notes from HCA and all of the notes provided by our coalition volunteers. And without exception, the retirees who have chosen UMP Classic Medicare had no negative comments to share about their plan, the coordination of care, or customer service. I'm not surprised by the data that was shared today that reinforces the fact that retirees with complicated healthcare needs choose this plan over the privatized options and Plan G. The plan offers comprehensive benefits, care is coordinated, medically necessary procedures are addressed, the medications prescribed by their doctors are covered, and the customer service teams that support this plan are knowledgeable and responsive. We saw a migration away from UMP Classic Medicare when the premium increased by 20% last year. In the stakeholder engagements, every person with this plan talked about the problem with the high premium costs. They said that for now, they would make trade-offs in their lives, trimming back on the household budgetary items in order to pay for the higher premium costs. With the plan now going up 22%, I'm left wondering what these seniors will do now. The seniors who have the most urgent and complicated healthcare needs. Based on their financial situation, they may be forced to choose plans that are not a good fit for their individual healthcare circumstances. Since last August, the coalition has requested HCA's help in seeking a federal prescription drug subsidy for government self-insured plans like UMP Classic Medicare to help lower the premium costs, just like the privatized options. We were told the letter would be out in October. We reached out to HCA month after month about the status of the letter. We are delighted that HCA finally took this much-needed step. From our lens, there are at least 2 important courses of action in the short term to help to provide financial relief to those who choose UMP Classic Medicare.
Lori,
Can I
just
wrap
give it. I'm just giving you. You're a little bit over, so just.
Okay, thank you. I will close by saying that the coalition has worked closely with HCA for the last year, and we hope to continue this partnership on the policy changes that will result from the learnings from the listening sessions, and we urge you to continue to work with us to find solutions to ensure that the healthcare needs of those with the highest and most complicated needs are addressed with the non-privatized healthcare plans. So thank you for this time.
Yeah, appreciate your comments. Sharon? She just disappeared. Okay, we'll come back to her. Annette?
Thank you. My name is Annette Barca, and I live on Whidbey Island, which is considered a rural area. And one of my activities is to serve as a SHEPA, or State Health Insurance Benefits Advisor, to my neighbors in community area. I'd like to add that we have many PEBB members that live on Whidbey Island because of its location. And I'd like to make a few suggestions. One of the things is that there be more specific information to help inform people about Plan G, as it is a viable option for some of the retirees, but they are afraid of it because they don't know enough information as compared to the other plans in the retiree information. I think that it's important that you be aware of some of the problems we have, particularly with United Healthcare here on Whidbey, is that many of the providers do not accept the United Healthcare plans in general because they've had too many problems getting patient referrals approved in a timely manner by the plan itself. And as a result, it becomes an option that is many doctors, including some of my own, will not accept. Even though United Healthcare says all doctors do accept it. It's up to the doctors to make the decision. I think that there also needs to be a better way for people who have the uniform medical to better compare the cost of their drugs rather than having to do one drug at a time. Whereas when I have worked with some of the people and trying to put together what is going to cost them for drugs through United Healthcare versus other, not through United Healthcare, but through United UMP, and at times even with United Healthcare, to find out what it's really going to cost them in total for their drugs, there needs to be a system that helps people understand what they're looking into. The fact that they do have a cap on the total amount of drugs in UMP is a bonus because they know that they're not going to spend more than the $2,000 for the prescription drugs. They do not necessarily realize what might be their copays in terms of Part D drugs until they meet their deductible. The coordination of benefits portion of the UMP is a factor that many people appreciate because some doctors will charge additional amounts because for the Part B injectable type drugs. I do want to thank you for, especially for, in terms of when you plan for these meetings, for having your agenda and your information meeting booklet available to us several days before the meeting so that we can go through and find out what's on the agenda and even do some asking of questions around our fellow colleagues in the organization. I'm with Washington Education Association so that we can better understand and be prepared for your meeting. And thank you for making time for us to make public comments.
Thank you, Annette. Francis? Come back to Francis. Lisa? Marcos?
Yeah, thank you. I sent an email into you. I don't know if it's the appropriate forum. I just have some issues with United Healthcare. It sounds like everybody does. Generally, I've been pretty happy with them, but I'm having trouble getting one claim paid. It's a simple fix. It's an administrative issue. They keep sending it to the wrong address. And this has been going on since September of last year. So I've contacted Washington State Insurance Commissioner, who referred me to Medicare, who referred me back to United Healthcare. And so I contacted the Public Employees Benefit Board, and they suggested I come to this forum to present my problem. So it's in an email. I don't want to take your time. If there's anybody who can help me get this resolved, I would really appreciate it.
Thank you, sir. Back to Sharon.
I'm just unmuting myself here. I'm also an RPEC member, and I'm glad to have the opportunity to hear these presentations. I'm also a uniform medical participant, and I am like Carol, I'm looking at budget things I can cut to cover that because it's vital for my husband and I. But I did go ahead as a really hopeful, not needed Plan B and look at Medicare Part D. And there's a $500 deductible shown there. And I'm thinking that would also add to the drug cost for me personally. But then, is this the one that would have a donut hole also? If this isn't the right forum, I can email.
Yeah, if you could email that question to us, that would be great.
Oh, okay. And I really just so approve of the letter that was sent. And I'm already formulating my letter to send to my representatives. Thank you very much.
Thank you. Francis?
Where is Francis gone?
And Lisa. All right. Do we have anybody from the audience? Oh, Elliot?
Yes, I forgot to ask this during the presentation. Earlier this year, I requested an update of an excellent report that Ellen presented last year. It showed the number of UHC appeals overturned. And I would love to see an update for last year now. And maybe it would be helpful to have it compared with Kaiser, another MA plan. So I'm just reasserting that request, and I did make it earlier this year as well. But I think that's a very vital piece of information that Ellen has presented to us.
Elliot, I'll just reassure you that was already on our list and is under development for one of the July meetings. I can't remember if it's the 12th or the 19th, but a refresh of that is definitely on the list. I do want to just make one other comment that I think is really important. I also heard when Ellen accidentally said the phrase "sick of" in listening sessions. I think the context she was saying that was that the board was tired of seeing Ellen. The agency is not tired of listening sessions. We're committed to them. They've been very valuable. I just think it's really important to say that publicly. And you know, we all love Ellen. Fred Yancey described her as user friendly at a previous, and that's she's very user friendly, and we appreciate all of her work. I think she was simply saying that she's been before the board a lot in the last year, whether it's dental, vision, Medicare. She is a staple of the presentations, and I think she was referring to the fact that you might be tired of hearing from her. I'm not tired of you hearing from her.
I'm not tired.
She's going to keep hearing from you, but more importantly, the agency. Very much. I agree with the comments from Lori during public comment. The listening sessions have been extraordinarily valuable. And as I said earlier today, so valuable that we are going to find a permanent work stream within our cycles for that activity because it has proved so valuable, both for members being able to reach HCA in a new capacity and for us to be able to really reflect on the things that our members are needing and hearing. So I think that was so important I felt really compelled to highlight that. So back to you, Chair McDermott.
Yep. Thanks everyone who spoke, providing your insights and feedbacks to the board. If you weren't able to speak today or have additional information to share with the board, you can submit written public comment to the email address included on the second page of the meeting agenda. Our next meeting is scheduled for Wednesday, July 12th, starting at 9 a.m. with the same format of attendance in person or via Zoom. And please note that our last two PEB board meetings of the season will happen on Wednesdays instead of Thursdays, as they have been so far this season. So that means July 12th and July 19th, both will be on a Wednesday. Dave, any final comments before we head into exec session?
At the next board meeting, we will be anticipating having any follow-up and final discussion and scheduling for action, the Medicare premiums that Molly presented today, and then our finance team will present the non-Medicare premiums. So that's for the non-Medicare retirees and employees. We're also anticipating that we will have an update on just kind of some of the general procurement activity that the agency has been undergoing, and a presentation about the WebMD implementation as the next facilitator and vendor of the Smart Health Wellness Program. So that ties back to a question earlier that Kurt, you asked about. We are planning a presentation about that transition for hopefully for next board meeting. We'll also get the 2024 board meeting schedule out there. We've been solidifying the dates and getting ready to file that with the code revisor's office. So we'll talk about next board season schedule as well.
Any final comments for the board before we go into exec session? All right. Executive session is going to happen here in the Sue Crystal Room for board members and included HCA employees. At this time, members of the public joining us in person at the Healthcare Authority today, as well as employees not part of the executive session, will be escorted by staff to the lobby for the duration of exec session. You'll be called back to join us in the Sue Crystal for the remainder of the public meeting, which basically is just a brief opening statement and adjourning the meeting. Pursuant to RCW 42.30.110 subsection 1L, the board will now meet in exec session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 4105.026. The exec session will conclude no later than 2 p.m.
2:30. Please change that to 2:30.
Because we needed to extend, we ran
Yep.
long, we need to stay till 2:30, Chair McDermott.
2:30. Exec session will conclude no later than 2:30. Board members, let's take a 5-minute break while we transition into executive session. Thank you.
Yeah.
And we're back to the public session. We are going back into executive session. We're extending 15 minutes, so we will be in exec session until 2:45. Thank you. All right, folks, we're back in public session, and this meeting is adjourned.